Live now, sir.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Madhya Pradesh chapter of Indian Society of Assisted Reproduction webinar on the topic PCOS New Guidelines Demystified. Before starting the webinar, we would have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Now, I would like to introduce Dr. Monica Singh, the convener of the Synergy Academic Club. Dr. Monica Singh is National Executive Member of ISAR. She is Secretary of MP Chapter of ISAR. She is also the convener of ISAR Perfection Series, Oxy Symbiosis Series, and this present is Now, I will hand over the session to Dr. Monica Singh. Support team,
डॉक्टर
please
वर्मा
mute
आपकी
everybody.
आवाज आ रही है.
Support team, please mute everybody.
Yes, sir.
Over to Dr. Monica Singh, madam.
Yes. A very good evening to one and all. And at the outset, I would like to really thank my own MP chapter of ISAR for being here today with such a big show. And Synergy Academic Club is just a sort of part of it. The whole thing is MP chapter of ISAR, which is the basis on which we have built up the foundation of fertility services all across MP in multiple centers. And the star luminaries of MP ISAR are today in this program with us, either as guest of honor, chief guests, special guests, and speakers, of course. So I have tried to put the maximum, the dignitaries of ISAR in this program. Our president, Dr. Patki, could not join, but we have got our chief guest, Dr. Sujata Kar, with us, Senior Vice President ISAR. We have got our guest of honor, Dr. Asha Bakshi ma'am, with us, General Secretary ISAR. We have Chairperson MP ISAR, Dr. Yatin Singh Verma from Gwalior. And we have two special guests, Dr. Archana Base, who is the president, the chairperson elect of MP chapter of ISAR, as well as so myself, Dr. Monica Singh, convener of this show. Let us go ahead with demystification of PCO guidelines. In the next 2.5 hours, we are going to walk you through the new PCOS diet guidelines, how they can be dissected according to the clinical spectra they have changed over the next decade. How are we going to decode PCOS by Dr. Kaveri Banerjee from Delhi. Next, we'll have the clinical management. How are we going to strategize that on the basis of these guidelines by Dr. Kundan Engle, Managing Committee Member ISAR. And then there'll be a panel with, panelists from all age groups from MP. So at the outset of the program, after thanking God Almighty, I would like to welcome our chief guest for the day, Dr. Sujata Kar ma'am, who is the Senior Vice President ISAR. Madam has been instrumental in bringing IVF to Odisha. Her special areas of interest are polycystic ovarian syndrome, proteomics of male infertility, and stem cells in gynecology. She is practicing since the last 3 decades. Madam is a gold medalist and has been credited with the first IVF baby of Eastern Odisha, as well as the first TISA baby, frozen embryo baby, laser hatched babies of Odisha. She has been awarded with the Parichya Award for Women Achiever in Odisha 2019 from the hands of Honorable Governor Odisha, Devi Award for Dynamism and Innovation from CM Odisha, as well as the Brand Icons Excellence Award 2018 for the Best IVF Center in Eastern India. She is an avid researcher and academician, has given 18 original publications over the years, male infertility chapter in PubMed, many chapters in books and newsletters, and she is a reviewer of many international journals. We know her as our very dear and affectionate honorary past Secretary General of ISAR, when she held our hand and led us through our journey of ISAR. She's also held various posts in PCOS Society, FPS of India, as well as the chairperson of Odisha SAP chapter of ISAR. We welcome you, Sujata ma'am. We are so honored to have you amongst us. And ma'am, we'd like to have a few words of blessings from you.
Monica, thank you so much. Good evening to all the, everybody who's joined in, all the faculty, your MPSR members, your Synergy members. Thank you very much for giving me this opportunity. And I'm really sorry that I seem to be in the dark. I'm actually traveling, got a little late in the OT. But anyway, so Monica, I'm actually very impressed by the various lovely terms that you find from somewhere. Earlier, it was the perfection series that I was so closely, watching when I was the secretary, ISAR, and then I think you had another symbiosis, and then this is a synergy. And it was I did try to find out what this synergy club is about, and I think it's a very new idea. And all the team leaders that you have, I'm sure you have quite a few of them who have logged in now also. Congratulations for this very novel and very nice idea. The fact that you have a small group of gynecologists who are actually keen on propagating the cause of gynec CMEs and education through webinars is very nice. And I love the words that you seem to be finding. Now, once in ISAR, then you have to find such catchy words for us also for various programs, which of course, even Dr. Amit Patki, our president, seems to be having so many programs going on. But anyway, to come to the point, Monica, today's topic that you all have chosen also is very, very pertaining and I think very much in the need of the hour, which is to make the general gynecologists, general those who are practicing infertility and reproductive endocrinology about the new PCOS guidelines. In fact, this is the new, the most recent update 2023, which I am sure you're going to cover. So that is a fantastic topic that you've chosen. Also, I wish to let you know that I hope that all those who are attending this webinar today will become PCOS Society members, because through PCOS Society, when this guidelines came out, our president, Dr. Durusha, she sent a ready reckoner. It's a printed booklet of about some 50 pages or something, very nicely and with big words, big fonts. It's a ready reckoner about the new PCOS guidelines. So which, as consultants, we can keep on our consulting table, and whenever need be, you can go through and look up as to what you're trying to see, and you can even show the patient and convince them that, see, this is the guideline, this is what the guideline says, this is how you should be doing, etc. So yeah, I think your endeavor is towards the right path, and I'm sure you have very nice talks. I think Dr. Ashish Kale is giving a talk today,
Kundan,
and
madam.
there's a very Kundan English is giving. I'm sorry, Kundan and Kanti. Yeah,
Kaveri,
and
Kaveri.
there is a panel, Kaveri, and there's a panel also, fabulous. I wish you all the best also in today's webinar and for all the future endeavors that you do.
Thank you.
And
Thank you
thank
so
you
much.
once again, all of you, for having me.
Thank you, ma'am. It is so nice to have you as a chief guest speak to us. And it was always a pleasure working with you, ma'am. And we still remember your programs with that one foreign faculty speaking to us, and Ritu Hinduja introducing one nice recent research paper. And I've also had the privilege of participating with ma'am in Kochi in that program. And now ISAR is going ahead with the Catalyst and Excellence series, Soliloquy. So we are doing a great job. Thank you so much, Sujata ma'am.
Thank you. Thank you.
Thank you. Thank you, ma'am. Now I would like to introduce our guest of honor for today, our very own Dr. Asha Bakshi ma'am, who is the Honorary Secretary General of ISAR. Madam has led Madhya Pradesh through various stages of growth of ISAR in the form of national conferences, state conferences. She is at present holding the post of Secretary General of the largest fertility organization in India. And Madam is the founder chairperson of MP IAGE and MP ISAR both. She is holding a very important decisive position in the PCPNDT matters of the state. Madam has
Monica,
held various important
bus.
positions in the past. Thank you so much, ma'am. So, ma'am, I think everybody knows you, but we want to listen to you, ma'am, for a few minutes before we start the formal program.
Thank you very much, Monica, for inviting me at this platform. And I'm really proud to be Secretary General of ISAR, which is an organization led by Dr. Amit Patki and having members of more than 6,300 now. So it is really increasing. And I want all of you to be active members of ISAR and encourage more members and more academically oriented people. And I really congratulate Monica for taking up such good academic program, and this is what we need now, because this really interests the younger generation. So these programs will really, and I feel that now it's high time that we have our own data, our own publications, our own guidelines, and I think this is high time. So all these programs will, I'm sure, encourage the youngsters to do so. And heartiest congratulations, Dr. Yatindra Verma. And of course, Monica, you are the secretary for MP ISAR. You all are doing very good activities. And I think recently there were elections, and Dr. Monica, who got elected recently? You got elected?
Yeah.
Because
yes,
there was
ma'am.
an MP,
No, ma'am.
IG and MP.
No, ma'am. The ISAR election was for honorary librarian, ma'am.
Okay,
Librarian,
so Dr. Shweta Kaul Jha elected, so heartiest congratulations to Shweta. And today this whole program is on PCOS and the latest guidelines on PCOS. I think PCOS is such a prevalent problem of our country, and there are so many myths about it, and at the same time it is being overdiagnosed also. Any girl people see and they say it is PCOS, and maybe it may be the other way around. So I think it's very important that we get lots of tips from Dr. Kaberi Banerjee and Dr. Kundan, and through the panel discussion that you are moderating, and lots of clinical tips and exact diagnosis and how to deal with will be evident. So I think I should not waste a lot of time, but it's really nice to see you all and wishing you all the best. Thank you.
Thank you, Asha ma'am, for those nice words for the program and for all of us. And we would really appreciate if you could get some expert comments from you and Sujata ma'am. If in the middle you could just, peep in and see how it's going, then probably things might interest you, because we have a lot of, good things in the program today, which are going to give us carry home message for our practice. Thank you very much, Dr. Asha Bakshi ma'am.
Sure.
Next, I would take the honor of introducing our very own chairperson, MP ISAR, because of whom this program could take shape. And we have been working together for last 2 years after ISAR Bhopal. And we have shaped the society into many youngsters coming into MP ISAR and doing good work. And we plan even more academic activities in the next years. Dr. Yatin Singh Verma is trained in IVF, ICSI, and cryopreservation. He is the chairperson of MP chapter of ISAR and also the director of Dr. Verma Hospital Fertility Center, Gwalior. His area of interest is embryology. He has got the Healthcare Award in October 2019 for excellent work in medical field. He is organizing chairperson of MP ISAR, which was held in 2023 in Gwalior, and the organizing vice chairperson of the National 27th Annual ISAR 2023, which was held in February 23 in Bhopal. Thank you so much, Yatin sir, for giving us this opportunity. And we would be really happy to have a few words of blessings from you.
Thank you very much, Dr. Monica, for the kind words. And I will not take much of time. And we are ready for starting this webinar. I welcome all the dignitaries here for this webinar. Please start.
Thank you, Yatin sir. Thank you so much. And now I would like to welcome to the program our special guests for the evening, Dr. Archana Baser madam and Dr. Charudat Joshi sir. but Dr. Charudat Joshi, a special guest, is here. So I will take the privilege of introducing Dr. Charu Joshi, sir, for all of us. Sir is the chairman of ISAR Embryology, which is a very big national post heading embryologists all over India who are a part of ISAR. As we can see, sir is a postgraduate in life sciences with doctorate in life sciences, trained in ART and all the advanced allied procedures from all over the world, served as office bearer in all the important societies where embryology is a part, like ISAR, IFS, ACE, ISSS-RF, and ISPAT. Served as past vice president of ACE, past president of ACE, and the medical director of GEES India ART Bank, which is doing a brilliant job in Indore. Sir is also the lab director of RD Gardi Medical College IVF Unit, Ujjain. We welcome you, Joshi sir, and kindly address us with a few words.
Thank you, Dr. Monica, for such a nice introduction. And it is always a pleasure to attend such kind of academic feast, and particularly when it is organized by MP ISAR under your guidance. And I always feel that this is the need of the day, because lots of centers, lots of new people are coming up in this field, and in-depth knowledge is required. And I think these are the good platforms to offer such kind of knowledge. So I would like to thank you for inviting me here as a special guest. And without taking much time, I would like to hear the speakers, and let's go on with the program. Thank you very much.
Thank you, Charu Joshi sir. And now we begin the Synergy episode 7 with MP ISAR. And as you can understand from the word synergy, if Monica, Neetu, Purva, Nandini, all of us worked separately, the amount of output we would have put in would not be that much as when we synergize. So that is why we have synergized. So our combined output is manifold. So this is how valuable these girls are. They are very accomplished gynecologists of Bhopal, working in AIIMS Bhopal, working in OBGYN department of GMC Bhopal, and they work with me to create these beautiful programs. Thank you so much, Dr. Neetu Mishra, Dr. Purva Bhatku, Dr. Nandini Singh Bhati. Dr. Neetu is not with us today evening, but Dr. Purva is there and who will be conducting the program for us. Thank you very much. We start the first session.
Thank you so much, ma'am, for your kind words. Now moving to our first session, that is on the new PCOS guidelines dissected. I invite our chairperson, Dr. Malti Bhujwani ma'am, Dr. Anju Verma ma'am, and Dr. Jayashree Sridhar madam. Dr. Malti Bhujwani ma'am, madam is presently director of Malti Hospital and Test Tube Baby Center, which is an advanced healthcare institute having world-class facilities. She has been a very active member of our Bhopal Obstetric Gynae Society. We welcome you, ma'am, to chair the session. Next, we have Dr. Anju Verma, ma'am. Madam will be joining shortly. She is presently infertility specialist.
Dr. Anju has joined. Dr. Anju has joined. Purva.
Yes.
Yeah.
Madam is presently infertility specialist of Dr. Verma Hospital and Fertility Center, Gwalior. She is a vice chairperson MP chapter ISAR, organizing secretary MP ISAR 2023. She has been credited for delivering first IVF baby, first ICSI baby, and first egg donation baby in Gwalior. And she has been awarded FICOG and is very active member in various societies like ISAR, IFS, ESHRE, and the American Society of Reproductive Medicine. We welcome you, ma'am. Next, we have Dr. Jayashree Sridhar, madam. Madam is presently Director Consultant, Vishesh Jupiter Hospital, Indore, and she is also very senior gynecologist and IVF specialist working for more than 20 years in this field. We welcome you, ma'am. Now I hand over the session to our chairpersons to introduce our speaker, Dr. Kaveri Banerjee, ma'am. Thank you.
Hello. Good evening, all. Let me first wish you all a happy Christmas, which is already yesterday we have seen, and also a very, very happening and happy new year to you all. And at the same time, I'm highly thankful to Dr. Monica and the team to give me this opportunity to introduce Dr. Kaveri, a very dear doctor. And let me see to her credit, so many things and so many awards are there. She is medical director, Advanced Fertility and Gynecological Center. She is alumni of AIMS New Delhi, and she has to her credit FRCOG London, UK. She is Commonwealth Fellow in Reproductive Medicine, and also she has received many awards like Bharat Jyoti Award, India Today Excellence Award, Bhailal Bhai Jhaveri National Award, and Price Waterhouse Coopers Award, Economic Times Award, and also IVF Icon Award Asia, and also IVF Icon of India Award. And to her credit, there are more than 50 articles published in the national and international journals of repute and numerous original research work. So I here invite Dr. Kaveri to throw the light on the recent guidelines of the PCOS, which is a very important topic.
Thank you very much for the
Yeah.
kind introduction. And I thank Dr. Monica for giving me this opportunity and all MPSR team to allow me to share on such a wonderful program curated by Dr. Monica and her team. So the topic today is the new PCOS guideline dissected, and I shall be mainly talking about the diagnosis, the lifestyle, and will not cover the ovulation induction or other aspects of this guideline because it's beyond the scope of the time. And also, I feel that, and Dr. Monica and I felt that the other aspects of the guideline are also extremely important to know the basic understanding of. So, we all have been following the Rotterdam criteria till very recently, and as we all know, out of oligomenorrhea, hyperandrogenism, polycystic ovaries on ultrasound, where there was the presence of 12 or more follicles in one ovary, either two of these three criteria, it would make the polycystic ovary syndrome. It had various downfalls of the criteria, and multiple modifications, including phenotypes, etc., came in. And very soon in 2018, the ESHRE, the Australian Society, and the ASRM came out with this international evidence-based guideline of PCO diagnosis and management. It was an extremely well-curated guideline. And it also had, like one of our chief guest, Dr. Carr, mentioned that the PCOS Society has many handouts, and even 2018 had wonderful handouts for PCOS to be covered, right from diagnosis to emotional well-being, treatment, and lifestyle. Having said that, there were few other aspects that needed to be covered, and then came the 2023 updated guideline of the previous guideline. And my next few minutes, 20 minutes, would be covering what have been the main features of this updated guideline. Now, the 2023 guideline offers a more nuanced and comprehensive recommendation reflecting advancements in research and a deeper understanding of PCOS. It emphasizes, in fact, it re-emphasizes individualized care, multidisciplinary approach, and addressing both physical and psychological aspect. So whenever we, as a fertility expert, and I shall be dwelling more on adult PCO, and the adolescent would be taken later on in the panel discussion in further detail. So whenever we think of PCO, it's, lose the weight, do the diagnosis, treat the hyperandrogenism, do the ovulation induction, and get the pregnancy. Somewhere in this, of course, lifestyle is very important. And as patients and as doctors, we struggle to get it right, to get the lifestyle in place, which in many instances is the key to success. Maybe you will not need all that ovulation induction and IVF if you have these initial basics in place. And also PCO is surrounded with multiple comorbidities. We all know that, but what are we doing about it in our clinics? Are we truly and fairly addressing them to our patients? Are we guiding them the way we ought to as practitioners, both in fertility and as a gynecologist? Is something this guideline clearly emphasizes and makes it clear. So the 18 guideline, for those who have read, and the 23 guideline, if you look at the diagnostic criteria and assessment, the 23 guideline maintains the Rotterdam criteria but provides updated recommendations on the assessment of hyperandrogenism, use of ultrasound, particularly in adolescents, and clearer guidance on distinguishing PCOS from other differential diagnosis. And this is something I will dwell in a little bit in detail. Also, when it comes to lifestyle management, it reinforces lifestyle management as foundational therapy and introduces more specific recommendation on diet, activity, and psychological support, and also digital health interventions that may make it easier for lifestyle changes to be implemented. For the pharmacological treatment, again, there is an update on the safety profile of COC, anti-androgens, insulin sensitizers, and guidance on the various weight-reducing drugs, inositol, which we are all, sometimes we prescribe, sometimes we don't. So it is a more updated pharmacological advice given in that. And finally, in the fertility aspect, on ovulation induction protocol, re-emphasizing letrozole to be the first line agent, and also when to move to IVF. And it has readdressed the implication of PCO and pregnancy and long-term reproductive health, which was not much addressed in the 2018 guideline. So whenever there is a guideline, there are certain recommendations, EBR, CR, and PP. What does it mean? EBR is evidence-based guideline. So that means there is enough scientific paper to say that this is what we should be doing. CR is consensus recommendation. That means the group that has given this recommendation feels that with some evidence from the general population, this is the recommended practice. And practice point is the evidence is not sought. The group feels that this is an important thing that must be added in the recommendation that is being formed. Again, it has few algorithms, so it's a huge guideline of about 200 plus pages. But at the end, there are beautiful algorithms which gives it in synopsis as to how we can go about the diagnosis, the risk assessment, emotional well-being. This is a very important part of PCO, and we recently had a National ISAR Congress on how ISAR can come up. Dr. Asha Bakshi ma'am was leading that, and in that emotional well-being, and of course with Dr. Amit Patki sir, is so important. And somehow again in our reflex to get the pregnancies going, we sometimes seem to give as much importance to it as it is due. Lifestyle was the next algorithm. For non-fertility issues, what medications, and for fertility, what needs to be done. So let's deep dive into algorithm 1, which is the screening and diagnostic assessment and risk assessment. So the diagnosis has become very clear now. You need just 2 points. One is irregular cycles, and the second is clinical hyperandrogenism. So if you have these two, then you have the diagnosis of PCOS. But what do we do if there is no clinical hyperandrogenism and only irregular cycles? Then you test for biochemical hyperandrogenism. So you do your testosterone levels. We will come to that. And once that has come, and say you have just irregular cycles or hyperandrogenism, just clinical hyperandrogenism, then comes the role of ultrasound. And in ultrasound, they have increased the number of follicles in the size of 2 to 9 to about 20 per follicle. And they have also added AMH to be one of the criteria to be added as a diagnostic criteria in adult. It's either ultrasound or AMH. So we'll come to these in detail. So let's just get it clear first that in Rotterdam, it was the two of these three, but now it's just irregular cycles and hyperandrogenism. So once we come to irregular cycles, and they have gone deep into adolescent cycles, and the reason they went deep into that was the overdiagnosis of PCO in the adolescent age group. And so I'm going to cover the adult part of it. And in adult, the irregular cycles is what we know. If it is more than 3 years from the onset of menarche, it is less than 21 days or more than 35 days or less than 8 cycles in a year. So if any woman has this, the next thing you should see is, does she have hyperandrogenism? Is there acne? Is there hirsutism? And if there is no such, then you do your testosterone levels. So clinical hyperandrogenism in adults can be acne, female pattern of hair loss, and other hirsutism factors. You have to again understand that this patient, I have seen so many PCO patients break down in front of us during the consultation because of the years of trauma of body image, body shaming, society that they have faced. And it is time we acknowledge that and extend a support of empathy towards them and also include the family spouse in our discussions. So hirsutism is very important for the young girls also and for the women we treat for fertility. So sometimes it's difficult to diagnose hirsutism because they treat it before they come to us. So it is important to also ask a few questions or maybe take the patient in isolation where she will more freely give history of her hirsutism. Clinically, as we know, acne is to be seen whether there is blackheads or whiteheads and whether there's pustule, whether it is affecting the entire face area or the shoulder area. And of course, the modified Ferryman-Gallwey score for the hair, we should know the various areas that we need to look, the upper lip, chin, chest, upper abdomen, arms, thighs, upper back, lower back, and then grade it from 0 to 30 score. And anything more than 6, in some studies it's 8, is hirsutism, and anything more than 15 is severe hirsutism. So, of course, a quick clinical look gives us the impression, but it's always good to make an objective assessment of hirsutism. And the female pattern of hair loss, which is the Ludwig pattern, where you have the frontal hairline is there and there is a scalp hair loss, or it's also called the Oslin's Christmas tree hair loss. So it's important to just have a look as to how is the hirsutism and hyperandrogenism presenting. You'll see many times PCO women have little scanty hair, and so it's important to document that and bring it as clinical hyperandrogenism. Once this is done, so you have the two irregular cycles and clinical hyperandrogenism, but if it is not there and there is irregular cycle, then total testosterone and free testosterone is used for diagnosis, and it is done, it's a reliable assessment of biochemical hyperandrogenism is not possible on OCs. So when you do the measurement, you need to be sure that the lady is not on any other medication. So total testosterone and free testosterone, about anything up to 2 nanograms per deciliter. And this represents the biologically active form of testosterone that is not bound to proteins, and like the SHBG, and this is available, this is bioactive. And total testosterone is not used because it may not accurately reflect hyperandrogenism in women with high or very low SHBG. So if there's very high SHBG, the free and testosterone is actually low. So it is not in the hyperandrogenism range. So it is better to measure free testosterone with assays that are standardized in your city or area. Now you've come to this, but you also need to rule out certain other differential diagnoses of PCOD. So you see, we have not done insulin levels, we have not done LH levels. These are not there in the diagnostic criteria. What else is there? We will come later, but you need to rule out certain other conditions. And when will you think that I need to rule them out? One is if the lady comes and says, Ki doctor, my, the facial hair or the acne is suddenly becoming very bad. Or you already see that her Ferriman-Galloway score is 10 or 12. Or there is huge area in the scalp which is bald. Or it is a sudden onset that she was absolutely fine 2 months ago and then suddenly there is hair. Or her testosterone levels are very high or very low, or she's not responding to treatment when your diagnosis of PCOD was made. So in such conditions, you will have to think of differential diagnosis of PCOS, and these are mainly non-classical congenital adrenal hyperplasia, androgen secreting tumors, Cushing's, hyperprolactinemia, hypothyroidism, and hypogonadotrophic hypogonadism. So hypogonadotrophic hypogonadism will present as irregular cycles or prolonged amenorrhea without biochemical or clinical hyperandrogenism. And then you have to do an FSH-LH and you will see them to be either normal or low normal. And your HH diagnosis is made, so she's not PCO. Of course, you've done an ultrasound and you may not be able to see the ovaries clearly, but in the guideline, this has come clearly as a differential diagnosis. And another thing about hypogonadotrophic hypogonadism is once you stimulate them, they can sometimes give a PCO picture. So your ultrasound may not always be accurate, and you need to do FSH-LH to confirm that diagnosis. Now, for other hyperandrogenism condition is the non-classical congenital adrenal hyperplasia. In that, you will do, suppose a very rapidly increasing hyperandrogenism, you'll do a baseline 70 hydroxyprogesterone. You can also, you will refer to an endocrinologist who will do an ACTH stimulation test to confirm the diagnosis. And then again, very high testosterone levels, not responding to treatment, you will consider or think of ovarian tumors and try to rule them out in conjunction with an endocrinologist. And also Cushing syndromes with its may not present always with central obesity, moon phase, or buffalo hump, and may need further differential diagnosis to be sure that this is PCOS and not any other condition. Once we have done the, the biochemical part of it, then comes the ultrasound. So say there is just irregular periods, there is no hyperandrogenism, you are doing your ultrasound. And in the ultrasound, the Rotterdam criteria was 12 per ovary. And in this, the transvaginal ultrasound approach is preferred. And in that, you have to have more than 20 follicles number per ovary or an ovarian volume of more than 10. And in this, it is follicle number per ovary is most effective, followed by follicle number per cross-section and ovarian volume. Now, again, this was some discussion, more than 22 to 9 follicle per ovary when you screen in your sagittal longitudinal transfers. In PCO, at least in Southeast Asian population, we are getting, at least in the clinical of what I feel, up to 10, 12, 15, 16, 18, but more than 20 is not very, very common. So are we really overdiagnosing PCOD? Again, back with the Rotterdam criteria still, or is the Southeast Asian cutoff for PCOD slightly less than 20 per ovary? Is something again we discussed in the recent ISAR masterclass on PCOD, and soon we will come out with a consensus on that. Now, 2018 said AMH should not be used for PCOD diagnosis. So here they have given a little bit of a variation that specific to your locality or your ethnicity, they have not given a cutoff for PCOD AMH. So could be used for defining PCOM in adults as an alternative to pelvic ultrasound. Either AMH or ultrasound, and definitely not in adolescents because it's going to be high there. And AMH definitely has limitations. It's still high in younger population. It is lower in those with high BMI. Contraception can reduce the AMH levels. And though we know it has menstrual cycle, the AMH remains the same. It is clear that during ovulation, now more studies are coming, that during ovulation, the AMH dips slightly. So with all its, various patterns and factors that affect it, AMH still can be used, and 4 to 5 nanograms per ml has been the general consensus for overt PCO diagnosis. Right. Now we have this lady who's come with hirsutism, irregular cycles, 18 follicles. She's been diagnosed and she's come to you for fertility. So do we start doing the semen analysis and tubal test and just get on with it? No, hold on. We have to counsel about the other parameters that can affect her now during her pregnancy or later in life. And for that, what do we do? So, cardiovascular risk, increased cardiovascular risk, and for that, you have to have a fasting lipid profile and you must have a blood pressure that is measured at least annually. So, these two things, please remember, blood pressure monitoring and lipid profile beginning, and if there is derangement, as and when you feel it needs to be repeated. It's important for them. Impaired glucose tolerance test. So again, we know PCOS is associated with impaired glucose tolerance. So what do we do? Do we do a fasting blood sugar? Do we do an HbA1c? Do we do an GTT test? So it is very clear that GTT is the most accurate test for dysglycemia. And GTT must be done in certain conditions, and you can get away with fasting blood sugar and HbA1c in certain other condition. So preconception, that means your fertility patient has come, you'd rather do a GTT to establish if dysglycemia is overt or covert. Of course, when she's pregnant. Any obese PCO. Asians, the obesity rate, the BMI has been reduced to 23. Not Southeast Asian, Asians, which is the Japanese, the Chinese, that population. If there's a family history of diabetes and if there's high-risk ethnicity in PCO is very clearly written in the 2018 guideline. In 2023, they've not mentioned much, but Southeast Asia, our population is high risk for PCOD, and East Mediterranean is high risk. Even the Mexican population is high risk. So for them, OGTT is important. And the other second line for testing, that is fasting blood glucose or HbA1c. Then you need to know that there is obstructive sleep apnea, and if there is symptoms, then they need to be associated with your multidisciplinary team. Endometrial cancer is common in PCOS more than the non-PCO population, but the risk is about 2 to 6 fold, and you should have a low threshold for investigation. And when do you want to test for endometrial cancer? In the very obese ones with prolonged amenorrhea, irregular bleeding, persistently thick endometrium, routine screening in all PCOD for endometrial cancer is not recommended. And the treatment that they have given is a pragmatic approach, can include progesterone therapy in those with longer than 90 cycles. So you are not exposing the endometrium to amenorrhea for too long, and it is better that they get at least 10 to 12 cycles, if not 12, at least 10 cycles in a month, more than 8 cycles in a year. Sorry. Right. So this was the diagnosis. Then it was your overall metabolic syndrome, cardiovascular, sugar, sleep apnea, endometrial cancer. And now the very important, which we sometimes try, it goes back in our zeal for, at least I'm speaking for myself, fertility treatment. Though we have empathy, we have counselors, but they have really stamped it in this guideline that please look into their quality of life, see whether they have anxiety or depression, see if there is a psychosexual dysfunction because of this condition, what is their body image issues, and are they suffering from eating disorders? And this is very, very common in adolescents, which I'm sure Dr. Monica will cover in the discussion. And in that, the main tip is that mental health condition should be offered psychological therapy as first-line management. And we must avoid inappropriate antidepressants and anxiolytics. So, of course, we should give them when necessary with a psychiatric consultation and mental health consultation. So we have come from gynecological diagnosis to endocrinology to cardiovascular and now to mental health. So this is a condition that really needs overall management, and you should have your team on board, or at least you should have associated doctors with whom you will liaise for this one patient whom you want to give full treatment. In the behavioral, now we come to lifestyle, as to how before they go for treatment, how can we effectively implement lifestyle changes? What can we tell them? So goal setting is very important, and I am really this fan of the SMART goal technique. And what it is specific, measurable, achievable, realistic, timely. And this, you can do it for everything in your life, to be honest. You can achieve only those goals which are specific. You label it. You lose 2 kilograms in 1 month. It was specific. It was measurable. Is it achievable? Can this lady lose 2 kilograms in a month? You can say, okay, let's make it at least 1 kilogram in 1 month. Is it realistic and is it timely? So follow up. So let her come back in a month and see how it is going. You can have a team to do that. You could do it yourself if that's what you're enthusiastic about. But make it smart, make it measurable, make it timely. And then we go, of course, to the diet, where it is very clear, vegan, Mediterranean, your Atkins, no specific diet regimen. The main thing they have said is try to lose between 200 to 500 calories from your previous meal intake. And again, for that, you would need nutritional support. And if your clinic is offering that, that's excellent. Then comes exercise intervention. So in exercise for the adults, it's a minimum of 150 to 300 minutes per week of moderate intensity. So see how specific this guideline is. Moderate intensity is basically brisk walking, can be swimming, can be dancing, and vigorous is really your gym intensive training. So that is slightly less. And these are the targets that you need to give to your patient. So in a synopsis for your lifestyle, give them specific, measurable, achievable, realistic, timely goals, a calorie deficit diet, no specific particular diet name, increase their proteins and fiber that will reduce their hunger, and at least 45 minutes per day of moderate intensity activity. Finally, infertility, though my colleague Dr. Kundan will deal with it in detail, again in the algorithm they have given it very beautifully that you've done your diagnosis, you have to do the other homework too. You know, your thalassemia, your thyroid, your rubella, tubal testing, male factor, and optimize everything. The first drug of choice they have said is letrozole, which is good mono-ovulation drug. And if it is detected, you continue it for some time. If ovulation not detected, they have come to clomiphene plus metformin, and then gonadotrophins and or laparoscopic surgery. And then finally, they have come to IVF. There's not much mention of IUI, but I'm sure Dr. Kundan will dwell in detail about it. Just a few additional insights before I wrap up. They have mentioned about inositol. They have not been, inositol, they said, should be experimental therapy, and it's uncertain, it's very recent. So they have not really advocated inositol, but have not said that you cannot give it, at least in this, my interpretation of this guideline. It's still a drug that has not been used for a long time, so we are not sure of its safety and side effect profile. They have mentioned about anti-obesity medications like liraglutide, semaglutide, and they have said that it could be considered in addition to active lifestyle intervention. Healthcare professionals should ensure concurrent effective contraception because with the sudden reduction in weight, pregnancy can be possible for couples who are not keen on it right now. However, shared decision making is important, and we need to know the side effects, the potential long-term effect of it, and long-term safety data is lacking. Bariatric and metabolic surgery could be considered to improve weight loss for the resistant ones, and the general guidelines of bariatric surgery should be followed. It is the last line treatment for weight management. So they have mentioned bariatric metabolic surgery also for the severely resistant PCO patient. Laparoscopic again as a second line treatment after letrozole, after clomiphene citrate, and it has mono-ovulation. The risks of multiple pregnancy is less. So all these have been covered in the guidelines. So finally, there have been diagnosis, health risk, lifestyle, emotion, well-being, and management. With this, I will take leave of my talk and look forward to the next talk. Thank you very much.
Yeah, it was a very excellent presentation, Dr. Kaberi, and really very, very useful guidelines for that. Very, very wonderfully you have presented. Any questions from the audience? Can I take it now, Dr. Monica?
Yeah.
Or
Various nice talk, Dr. Kaveri.
Thank you.
And usually we have just discussed ovulation induction and management in PCOS on the fertility point of view. It's very good that you have discussed all aspects in PCOS, because as a gynecologist, we must focus the patient in other different scenario also, like metabolic disorder, cardiovascular disorder. I want to ask one question, according to your practice, when a patient come to you at the age of around 32, 33, because nowadays late marriages, patient usually not interested very much for conception, but they are having irregular cycle and PCOS in sonography and no hirsutism. So how you proceed for management, OC pills or just progestins? So what is your choice to giving OC pills or progestin, only progesterone? to prevent all these complications?
So you see, it depends on the severity of irregular cycles. If they are less than, if it is highly amenorrheic or less than 4 cycles in a year, then
Yeah.
progestin should be the preferred drug of choice. But otherwise, oral contraceptive pills are given, I give, and it is very clear you should give low dose oral contraceptive pills, and no particular combination has been shown to be better than any other combination.
Okay. And what about anti-obesity drug? According to your experience, you are using?
No, I'm still quite skeptical about it, and I've still not started. I'm waiting for my colleagues to start and see the
And
effect.
you are using metformin in adolescent for PCOS?
In adolescents,
Metformin.
I'm using it in fertility patients and in some adolescents who don't want to go to contraceptive pills. I am giving metformin in a gradual increased dose.
Thank you very much. Very nice talk. You just covered all the aspects.
Thank you so much. Thank you. Thank you.
Yashri ma'am, would you like to put in your comments?
Yeah, it was an excellent talk. You know what? To sum up, I think what she meant was we need to know the expect concerns and expectations of the patients. Like, ideas of the patient. What does she think of PCOS? And concerns is what is she scared about? Like, where we might be thinking she's already 32, so we need to counsel her for fertility, but maybe she's more bothered about her obesity. And liraglutide or even semaglutide has come up in a big way, and it is quite effective. My reproductive endocrinology colleagues have started it for the last 1.5 2 years, and they have reported good things. And expectations, again, what are her expectations of the treatment, and what is how long will it take? And we need to emphasize on the duration of treatment also. Excellent, Dr. Kaveri, and thank you, Monica, for having us.
Thank you. That's good to know that you have experience with the anti-obesity drugs.
Yeah.
Yes, I think Dr. Jayashree visited Bhopal recently, and madam, I think you have some experience with anti-obesity drugs. You did speak, Dr. Jayashree Sridhar.
Yeah.
On that, yeah. So I really feel that Dr. Kaberi, you have like everybody puts in the guidelines on the slides as
Very
they are,
expensive. We need
but
to
you
tell them.
actually
Sorry.
dissected them.
Yeah.
You actually gave us a fair share of your input in it. You simplified it beautifully. You put only the correct number of words and figures on the slide, which was
Yeah.
absolutely fantastic. And this 2018 guideline was more of IQ, but 2023 is more of EQ.
True.
2023 guideline has become softer, more emotional, more feminine. So I think it gives you that food for thought that PCOS is not an entity. She is a living woman. You have to deal with her, with all her emotional things in place. Thank you so much, Kaberi. You did
Thank you.
full justice to the talk. I'm so happy
Thank
to have
you.
you.
Under your guidance, Monica. We had a discussion and she guided me that, this is what the people would want. And so thank you for the
so much,
opportunity.
Kaberi. Thank you for pitching in just before New Year.
My pleasure. My pleasure.
Thank you.
Thank you, Dr. Monica, choosing so nice topic on PCOS.
Thank you, Anju. Thank you for joining.
Yeah.
We can go to the next talk.
Yes, ma'am. Very good evening to one and all. After gaining an in-depth knowledge about the new guidelines on PCOS, we move forward to our next topic, that is the latest PCOS guidelines and evidence-based management strategies by Dr. Kundan Ingwen, sir. The session will be chaired by Dr. Kusumlata Singhal ma'am, Dr. Monica Singh ma'am, and Dr. Aradhana Gupta madam. Dr. Kusumlata Singhal ma'am, madam is director at Koteshwar Hospital, Gwalior. She is also the Joint Secretary of IMA in Gwalior, and madam is also advisor of Gwalior Obsgynae Society. She has organized many FOXY affiliated conferences, including the Yuva FOXY, and she has also written a book on Drishtikon, which has an intention to change the mindset of Indians regarding female child. We welcome you, ma'am. Our next guest Our next chairperson is Dr. Monica Singh, ma'am, our own convener. Madam is the National Executive Member of ISAR. She is the founder president of ISOPAP chapter of Bhopal. Madam is Vice President of Bhopal
Okay,
Office.
that's okay, Nandini. That's okay. Thank you so much.
Thank you, ma'am. Thank you. Next chairperson is Dr. Aradhana Gupta, madam. Madam is director and consultant at Aradhana Test Tube Baby Center. She is also the managing committee member of MP SAR. Madam is Foxy accredited trainer for infertility courses since 2013. She has a varied experience of 29 years in the field of reproductive
That's
medicine.
enough. That's enough. Thank you very much.
We welcome you, ma'am, to chair the session. I request my chairpersons to kindly introduce the speaker for today.
May I introduce?
Yeah, please.
So, Dr. Kundan, I think we all know him very well. He is a very humble person, and plus he is very intelligent also. And we all know he is a chairperson Infertility Committee Foxy 2022-23, and managing council member ISAR 22 and 24 to 24. He is a director of Nirmiti Clinic, Center for Assisted Reproduction and Endoscopy, Pune, Vice President POX 2023 to 24, and founder, treasurer 2011 to 24, and librarian 23 to 25, Maharashtra chapter of ISAR. He has presented a research paper at ASRM 2020 on prospective RCT on of estradiol validate hemihydrate in FET. He is the owner of ART Bank also in Pune. So he is running both the business. He is doing IVF and ART Bank both, and presented first time research at 6th COGI World Congress at Vietnam on use of GCSF subcutaneously for thin endometrium. So, Kundan, we welcome you.
Thank you.
We are going to have a good academic feast that we are hoping with you.
Thank you, Dr. Aradhana, Dr. Monica, and Dr. Sumlata, chairperson for this session. Big thank to our Maharashtra, Madhya Pradesh ISAR chairperson, Dr. Yatindra Verma, and Dr. Monica Singh as a secretary for giving me this opportunity and for the very kind invitation to be a part of this CME on PCOS new guidelines demystified. And I think we have witnessed a fantastic lecture by Dr. Kaveri about, really dissecting those guidelines and giving us each guidelines meanings and kind of views. So today my part is going to be typically on infertility management about this PCOS patient. I hope my slides are clear to you and my voice is clear. Yeah. So friends, I have given this name as optimizing PCOS management protocol. So it is going to help us to dissect even infertility guidelines. So just to begin with, PCOS can be defined as though there is no standard universal definition right now, but it is a kind of a syndrome of hyperandrogenism and anovulation or oligoovulation in the absence of other hypothalamic, pituitary, ovarian, or adrenal disease. So that 4 organic pathologies are ruled out, and now it is only a syndrome of hyperandrogenemia and anovulation. Now, we are following this Rotterdam criteria where 2 of these 3 criteria has to be present. Dr. Kaveri has already mentioned about it, that either we can have a polycystic pattern of ovaries on ultrasound, oligo or anovulation, that is patient coming with anovulatory cycles, and also clinical or biochemical evidence of hyperandrogenism. You don't need all 3, you just need 2 of them. Now, what are those clinical and biochemical findings which are suggestive of insulin resistance? Because insulin resistance is a kind of a phenotypical representation of PCOS. You don't see or you can't elicit any signs just looking at the patient. So you have to do certain tests. You have to look for certain clinical findings also, like it is listed here. So most important, the first thing which is even our 2023 guidelines has suggested to do a glucose tolerance test. And if the fasting blood sugar, if it is more than 100, or 2-hour blood sugar more than 140, you can diagnose it as a insulin resistance. But you may get lots of PCO patient who does have a insulin resistance, but their GTT is not normal. I mean, that's not abnormal. It is still normal. So then you have to look for other clinical signs like obesity, waist to hip ratio we have to measure. You have to look for subcapsular skin fold or acanthosis nigricans, which is typical skin thickness at the nape of the neck. You may have a fasting insulin levels more than 30 MIU per liter. You may have a glucose to insulin ratio less than 4.5. Serum triglycerides may be above 55 millimole per liter, and patient may come to you with amenorrhea. That's very last clinical finding. But you have to look for these. So even if you have 2 or 3 clinical findings and you may have abnormal GTT or normal GTT, you can consider this patient as having insulin resistance. Now we need to understand that though the evidence is clear since a decade now, that majority we will see these symptoms and signs in obese PCO patients very obviously. But the most difficult to diagnose it when it comes to lean PCO patients. But we need to understand that the dictum has gone that lean PCO patients do not have a insulin resistance. They do have a insulin resistance. So we have to take efforts to diagnose them. And we have to understand that whatever picture we see, infertility, hirsutism, menstrual disturbances, or she comes with obesity and obesity related endocrine disturbances. But we must understand the major reason which is not seen, and that is beneath the water level, and that is insulin resistance, and we cannot miss it out. Now, the clinical features, patient will come to you in a different symptomology. I think Dr. Kabiri has already mentioned about it. We need to understand, and we are discussing about reproductive abnormalities, and patient will typically come to you that she's unable to conceive. Now, fertility management, as per guidelines, which we have to dissect now, and the first thing comes is about lifestyle modification. So what does guidelines says? So again, I'm going to repeat few things which Dr. Kabiri said, because she has mentioned about it, that your lifestyle modification must include a weight reduction, which is a combination of caloric restriction, increased physical activity, and behavior modification. And that's where the counseling plays a very important role. Now, weight loss, how much is enough, is again a kind of an ancient, that 10% weight loss, even guidelines says that will give you significant improvement in metabolic and reproductive function. So that evidence is still clear till 2023 that we don't need to ask a patient to go to the ideal BMI, which is difficult and time consuming, and sometimes patients do not cooperate or compliance is very poor. At least try and explain them and benefits of 10% weight loss, and that you can achieve, ask her to achieve it within 6 months. Okay, if you look at the proper diet chart as well as moderate physical activity, as mentioned by Dr. Kabiri, you can actually get it done within say 4 to 5 months also. Okay, and loss of abdominal fat is the best predictor of weight loss. So because we know gynecoid obesity is typically at the waist level, so abdominal fat level is something which is more common, and buttocks fat levels, fat deposition is most common in women. Now, how does it help? So it increases the sex hormone binding globulin concentration, and does it help us to reduce free androgen levels? Okay, so how should be the energy deficit? So energy deficit of 30%. Now, practically it is difficult for us to calculate 30% of every. So keep it very simple that I have to restrict her for 500 to 750 calories per day required for weight loss. So that kind of energy deficit, and that's where your dietitian plays a very important role. So 500 kilocalorie restriction daily equates to weight reduction of 1 pounds per week. Now, for that reason, your dietitian needs to know what is her usual diet, how much calories are going inside. Then she has to restrict from it, right? So first, a dietitian's job is to how she is living, what kind of food she is eating, how many times she is eating, what kind of food products she is using. So she has to calculate how much is going in From there, she has to restrict. And that's why it is very important. And diets restricted in carbohydrates typically provide a rapid initial weight loss. We have seen this, that the moment carbohydrate restriction comes in, you start seeing significant decline. At least you see that really, that at the end of 1 month, even if a woman has not done exercise, she'll lose 1.5 to 2 kg with severe restriction or diet restricted in carbohydrates. But yes, we need at least 3 to 4 kg is the weight loss rate per month. Okay, so there plays a role of exercise as well as diet chart. So adherence is very and the most important to the diet which is chosen. I always tell my patients that, at least follow 70 to 80% of the diet chart. It is very difficult, even if you tell somebody, and it is very difficult that 100% somebody will follow. But at least tell them that 70 to 80% you try and follow. It will help you to achieve that goal. And yes, when it comes to restriction, we need to understand that the diet cannot have a low quality diet. So you need to have an enrichment in fruits, vegetables, whole grains, lean poultry and fish. That should be encouraged to provide maximum overall health benefits so that she doesn't land up in nutritional deficiencies. Now, after weight loss, obesity drugs, can they help? Yes, guidelines does says that you can take a help of appetite suppressants, that phentermine and sibutramine. Sometimes even you can give absorption inhibitors like orlistat, which is also available in India. And you can select your specific patients, PCO patients who are morbidly obese. Those are the ones who are more than 35 kg per meter square and having comorbidities, or any patient who is more than 40 BMI. I think we must advise them to go for bariatric surgery, because it is going to be very difficult for them. They are going to take a lot of time, and we know in infertility our patients are they keep running for the time. Now, what is the mechanism of GLP-1 receptor agonist? I think which we discussed, which drug, how to use them in PCOS. So GLP-1 receptor agonists are how they act. So they help in reduction in body weight by increasing expression of glucose transporters in insulin dependent tissues. Okay, so it basically allows insulin dependent tissues to consume more insulin from the circulation through glucose transporters, and these GLP-1 receptor agonists, they increase this expression of transporters, because of which consumption of glucose increases, and it also decreases inflammation, reduces oxidative stress, and it modulates lipid metabolism. Like we have semaglutide and liraglutide, these are the products. So this was a good paper in 2024 about systematic review, and they said that glucagon-like peptide-1 receptor agonist, they effectively reduce body weight and improve some of the endocrine and metabolic parameters of polycystic ovarian syndrome. A combined treatment of these agonists along with metformin, they had a significant effect on the weight loss and also favorable results on endocrine and metabolic parameters. So especially our obese patient who has a prominent insulin resistance or even diabetes, I think giving them metformin and this agonist is going to really help, because they will, within 8 months time, with this drug and a diet restriction, they will be able to achieve at least 10 to 12 kg within 7 to 8 months. That kind of effect you get with these kind of drugs. Now, there was one randomized trial in 2025, that preconception interventions in infertile women with polycystic ovary. So here, lifestyle modification in what way? So one is calorie restriction with meal replacement, weight loss medications, and increased physical activity. This is what was and intention was to promote 7% weight loss. So accordingly, one group received OC pills, second group received lifestyle modification, as I just mentioned, and group 3 actually received both oral contraceptive pills also and lifestyle modification. So let us understand what have we achieved with any of these interventions. So cumulative ovulation rate, we found it more better in combined approach where you have given oral contraceptive pills and lifestyle modification, or even equally better if it is only lifestyle modification. But giving just oral contraceptive pills, especially about cumulative ovulation rate, you are not going to achieve much. So big no for only OC pills. Only lifestyle, yes. And if you can combine OC pills lifestyle, again, it is going to be beneficial. What about live birth rate? Again, not much difference between only lifestyle and combining OC pills and lifestyle, but only lifestyle again proven that it gives you better live birth rate than only alone contraceptive pills. So again, we have to take a step and counsel our PCOS patients as per our 2023 guideline that lifestyle modification is the first approach, and preconception weight loss intervention not only eliminates the adverse metabolic oral contraceptive effects, but compared with oral contraceptive pill, it leads to higher ovulation rate. Now coming to the next role after lifestyle modification and role of insulin sensitizers. And here first we are going to discuss about metformin. So this was a 2017 Cochrane review, and they compared here insulin sensitizing drugs like metformin, rosiglitazone, pioglitazone, D-chiroinositol, those for women with a PCOS. So they included 48 studies and 4,450 patients were included. Out of them, almost 42 studies have studied metformin. Sorry. So they concluded, though it was a low quality evidence, they concluded that alone metformin is maybe beneficial over placebo for live birth rate, which was a low quality evidence. They did mention that metformin versus clomiphene, means metformin only or clomiphene only, live birth rate inconclusive due to lack of evidence, and it is differed by BMI. So cannot apply general rule of using metformin as a ovulation induction drug or only clomiphene as a drug for any PCOS patient. Now, clomiphene plus metformin versus clomiphene alone, again they found that combination improved pregnancy and ovulation rate with combination. Okay, metformin alone or combined with clomiphene, there is no evidence of increased miscarriage, so they are safe, plus having good pregnancy rate and ovulation rate, and metformin associated with higher GI side effects. So these were the facts were concluded by Cochrane review. But does that mean that we must use clomiphene metformin? No. When this was the older evidence and including all those studies till 2017, we will discuss what is of 2018 onwards. Now this was a practice committee of ASRM, and they also said that there is a good evidence that if you use metformin in combination with clomiphene, it improves ovulation and clinical pregnancy rate, and it does not improve live birth rate compared with CC alone in women with PCOS. And there is a fair evidence that it clearly said, and till now everybody we follow, that we must pre-treat our patients having insulin resistance or PCOS with metformin for at least 2 to 3 months, and then you should start doing a ovulation induction. Okay, now can we give metformin as a monotherapy in a lean woman? So this was the only study for lean women in 2005, and where 17 patient having BMI less than 25 and 17 patient with having BMI more than 30. So lean was compared with obese, and they found that metformin will have impact, especially for lean women. It increases the menstrual cyclicity. So obviously she metformin makes her ovulate. That's why her cyclicity is better. Ultrasound evidence of ovulation is also significantly high and seen in lean patients, and pregnancy rate was also significantly better in lean women. So it's not like that lean women do not need metformin. They do also need metformin, and it is beneficial in having better ovulation rate and better pregnancy rate. So we need to stop discussing about only role of metformin in obese patient. It has got a significant role in thin patients also. So come to a myoinositol, that's a second drug now. It is considered as a safe and alternative approach for PCOS women by this German observational study, where 3,602 infertile women, they use myoinositol and folic acid for at least 2 to 3 months. Okay, here the dose which was used, if you look at very carefully, the dose which was used was 200 milligram twice a day. Okay, that is per day, it is going 400 gram. That's a quite high dose. In India, whatever we are using, we are not going beyond even 1100. Sometimes we go for 2000, but we are not giving 4 gram. And what is this paper says that if you use such a dose, then 70% they have restored ovulation, and pregnancy rate was been seen almost close to 15.1%. Not only that, the before treatment, the total testosterone levels were 96. They brought down to 43. Even the free testosterone significantly was reduced from 1.2 to 0.35. So it decreases the hyperandrogenemia in PCOS patients. So I brought this study because it was large size and a better done and with a different dose, that is 2000 gram twice a day. Okay. So we need to understand that minoxidil, when it was compared with control group, it improved HOMA index, it increased estrogen level, and there is no strong evidence that minoxidil has an effect on total testosterone level. But there was, when it compared metformin and minoxidil, they found there was no difference in controlling, fasting insulin or HOMA index or testosterone level, SHBG levels, BMI. It was almost similar efficacy from this meta-analysis in 2019. So it was a strong evidence of increased risk of adverse event when metformin was used, and that was very, very less with minoxidil. But what dose, minoxidil should be used? And this is what one study, I think this was a double-blind randomized control trial in 22. Again, in this group, see, this is all after 2018. Now, 2023 guidelines are also there. So we need to understand that these 50 patients in this study of 22, they received 2 gram twice a day. That means 4 gram of minoxidil per day. And it was compared with 1.5 gram of metformin per day, right? So that's ideal dose comparison. And this was a double-blind randomized control trial by Dr. Kirtana Rajasekharan. And they have shown that there is a significant increase in clinical pregnancy rate as well as cumulative pregnancy rate. This is all patients who are PCOS patient undergoing IVF with GnRH antagonist cycle. So here frozen embryo transfer was planned. So all cumulative pregnancy rate for all patients, those who received minoxidil, they had significantly better pregnancy rate, clinical as well as cumulative. So somewhere probably what we were used to think that there is a lack of evidence of minoxidil, but now we have good evidence coming on, and we are getting now evidence about the correct dose of minoxidil, that is 4 gram per day. So this was, if we are getting a better results with minoxidil, which has got a least side effect, and with metformin having gastric intolerance, and then that's a, you need to compare, you need to go for this evidence and start using into your practice. Now, what can we do? Again, oral contraceptive pills. Now, see, I'm going slowly, step by step, like as I see the clomiphene, obese or PCO patients, how lifestyle modification I will advise, what pre-treatment I will give. Now coming to another group of drug which is used as a pre-treatment in PCOS patient, and that is oral contraceptive pills. So if you look at the IVF evidence, we don't want to use oral contraceptive in IVF because it increases miscarriage rate, it reduces live birth rate. But when it comes to treatment like ovulation induction and IUI, I think to get the adequate ovarian response, we will use oral contraceptive pills only for a transient 1 or 2 cycles just prior to your treatment cycle, especially for those patients who's got a significantly high LH levels in their circulation when you do this FSH LH on the second day of menses. And if you have a LH beyond 7, 8, like somebody may have on day 2, 10, 15, 18. No, these are the patients who will always have suboptimal response to your ovarian stimulation. And there, if you give oral contraceptive pills at least for 1 or maximum to 2 cycles, circulatory LH level goes down so well, and your ovary responded so perfectly to your ovarian stimulation when you expect that ovary to produce 1 follicle or 2 follicle, and that kind of, so you don't get resistance, drug resistance cases. So where you have given oral ovulogens and there is no response of follicular growth, that kind of situation is really, really low. So that is another 2023 guidelines says that we can use oral contraceptive pills, but only for 1 or 2 cycles. It's not like that we have to give a prolonged suppression and it's going to have benefits. No. Now coming to 2018 onwards. So this was a study in 17 where a letrozole was compared with clomiphene, and one of the most important biggest advantage that letrozole had a 0% case of a case report of ovarian hyperstimulation when it was used as a oral ovulogence, and that was 6% in clomiphene citrate patients, where we had to cancel the cycle due to HSS. That was almost 6%. That was 0% with letrozole. And endometrial thickness was significantly better with letrozole. Even the pregnancy rate, that is biochemical pregnancy rate, was better, and it was in favor of letrozole. So 2017-18 later, we started using again letrozole, and that has become in since 2018 as a first line, and even 23 guidelines, they say that letrozole is your first choice of ovulation induction drug. Now, this was a double-blind multicentral trial that was in 2014, and which clearly said that if a patient who is undergoing, say, treatment, and you want to do a live birth rate calculation, the cumulative live birth rate was significantly with letrozole. Cumulative ovulation rate was significantly with letrozole. The pregnancy loss and twin pregnancy rate was not so significant difference between both the drugs. So, but the outcomes were better. And if you look at these guidelines, they say that letrozole is associated with a better outcome, as well as if you combine letrozole with human menopausal gonadotropins, they have a significantly better endometrial thickness, and also the estrogen levels are better, and the pregnancy rate has been reported to close to 55.7%, which is a cumulative. So they say that if you use letrozole with HMG, average medication time is 2.9 weeks, and it is significantly shorter than those compared with other drugs like clomiphene and letrozole. So you get a better and a faster follicular growth. They ovulate little early, doesn't matter, but you will not have cancellation cycle rate due to non-response or poor response of the ovary. So these were the evidence which was available. Letrozole has been associated with higher rate of ovulation, more dominant follicles, better endometrial thickness, higher clinical pregnancy rate. Okay. Though it was mentioned higher multiple pregnancy rate, but not so much difference, lesser adverse effect, and higher acceptability. So letrozole has been proven that is the first kind of first preferred dose. Now, shall we use 2.5 or 5 milligram? So this was a comparative prospective randomized trial, and they found that the total number of follicles was significantly higher in patients receiving 5 milligram of letrozole, and pregnancy rate per cycle receiving 5 milligram of letrozole was statistically higher than patient receiving 2.5, that was 26 versus 5.9%. So even these papers have clearly given us 5 milligram has got a little advantage, but can we still go further and use 7.5? So this was a prospective randomized trial. This study did not show any advantage of using 7.5 over 5. So 5 milligram should be okay. Now, what guideline says? The guideline says that minimum at least 2.5 is sufficient to have a single dominant follicle. But if you use 5 milligram, you will have 1 or 2 follicles more. And I think you'll obviously the pregnancy rate is going to increase when you use 5 milligram. Now, another question that always literature discussed about, whenever you want to use clomiphene as ovulation induction drug, give metformin. It gives you better drug, right? What about letrozole with metformin? Can we give that letrozole with metformin, or just letrozole is sufficient? So this is very important question, and this was another study, and this was in 2016, and when it was compared letrozole with metformin versus clomiphene with metformin, small size study, retrospective nature of the study, that are the limitations, but they found that with letrozole with metformin, thickness was better instead of clomiphene and metformin. If you look at the pregnancy rate at first induction cycle, it was 17% with letrozole plus metformin, and it was only 6.4% with clomiphene metformin. If you look at 1, 2, 3 cycles, at the end of 3 cycles, again, it was significantly better with letrozole with metformin. So it gives us clear idea that even if you have a patient who's PCOS, having insulin resistance and infertility, and you want to plan ovulation induction, but she is an insulin resistance patient, you must give metformin, and then you can, after metformin consumption, you can start ovulation induction with letrozole. How you will start? So this is a good protocol in a diagrammatic way, where you will give letrozole 2.5 to 5 milligram, totally your choice. I always feel that to begin with, you start a first cycle with 2.5 milligram per day. Depending on her first cycle, if she doesn't conceive, you can modify your second cycle protocol. So you start from second day, preferably start and particularly on second day. It will help you for a better follicular growth, and give it for 5 days, and you keep monitoring from 7th day, and depending on the size of the follicle. And once the follicle is 18 to 19 millimeter with Doppler showing a good flow, you can give SCG trigger and then do a IUI. Now, this is another protocol for IUI, which was given for like a low dose FSH, but I think this consumes lot of injections and lot of gonadotropins. So I think this is not the preferred right now drug, because it consumes lots of gonadotropins. The duration of stimulation is higher. So another protocol which was, once the letrozoles, for example, any PCO patient, you have given a letrozole 2 IUI cycles, 2 ovulation induction cycles. If she ovulated but did not get pregnant, another 2 cycles you can plan with letrozole along with HMG. Now, this is something which is not given in guidelines. This comes with the experience-based guidelines. Okay, that says that if you give letrozole for 5 days, followed by gonadotropins right from 7th day, like in a 75 IU or 150 IU daily till the day of SCG, means you are giving daily HMG. And here you will typically see that you will have at least 2 dominant follicles into this protocol, which is good because it is going to improve our clinical pregnancy rate. Now, I have another suggestion, which comes from my own study. That is, what we do is we give oral contraceptive pills for 1 cycle, followed by we start from the second day letrozole, but we give only for 2 days. So we take advantage of pushing this FSH level just beyond threshold, so that at least 2 or 3 follicles will get recruited, and then from 4th day onwards we add HMG or gonadotropins in the dose of 75 IU or 150 IU, depending on the antral follicular count. Then we keep that FSH level, same level above the threshold, so we don't see any follicular atresia. And typically with letrozole, you always have 2 to 3 dominant follicular recruitment. Those kind of 2 or 3 follicles will continuously grow into dominance, and there is a little chance of premature LH surge. So we can monitor LH. If necessary, you can use antagonist and prevent premature LH surge. And once the follicles are ready, you can give a trigger. So this is also one of the good protocols when you are targeting controlled ovarian hyperstimulation. So guideline says letrozole is your first choice. Okay. Pure gonadotropins comes as a second choice. Now, there is between these 2 first and second choice, this is something which I wanted to highlight from my side, that you can combine oral ovulations and gonadotropins in your 3rd and 4th cycle if necessary. Okay, this was our own observation for last 4 or 5 years, and we wanted to check what is the clinical pregnancy rate. So those patients who undergone with these protocols, we had almost clinical pregnancy rate of 17.48% per cycle, means that is per ovulation induction cycle. So every month you have a 17% pregnancy rate. Okay, if you look at the per patient, means number of patients start undergoing treatment, so we saw that cumulative pregnancy rate was almost 31%, means our total recruited patients, 31% patients were pregnant, and none of the patient had a mild to severe OHSS with this. So that was another advantage which we, what about the multiple pregnancy? So only 1 patient out of 25 pregnant patient had a triplet pregnancy. That comes to only 4% multiple pregnancy rate. Twin gestation was almost noted in 6 out of 25 patients. So 24% twin pregnancy rate, and 72% had single gestation. So I can understand that with gonadotropins, and we know this fact, even guidelines says that we have to counsel our patients that whenever you want to use gonadotropins, the multiple pregnancy rate we have to explain, but this was around 24%, which was a twin pregnancy rate. It was not more than twins. Okay. Again, this was a good evidence in 24 that GnRH antagonist, 2014, sorry, this was a meta-analysis that if you use antagonist into ovulation induction and IUI cycles, whenever you have a impending premature LH surge, it does prevent premature utilization rate and thus saves our cycles for cancellation, increases the clinical pregnancy rate. And again, this was a good study in 2019 when all PCO patients undergoing COH and IUI cycles, as we just mentioned, and GnRH antagonist was used. LH surge was very, very minimal where antagonist was used, Premature progesterone rise was only 11.5% versus 26, and premature luteinization was only in 1.1% than 17.2%. Of course, we did see monofollicular cycles almost in favor of using antagonists. So antagonist is good because it helps you to, it helps you to prevent premature LH surge, one of the main reasons of failure of the cycle. Now coming to pure gonadotropins. Now we have understood letrozole, then letrozole with gonadotropins, and now pure gonadotropins. So friends, this was a study way back in 2015 when low dose HMG was compared with clomiphene, and where low dose means low, almost 37.5 to 75 IU. That was started from second day per day, and this was compared with 50 milligram of clomiphene per day from day 3 to day 7. And they found that all the parameters, CPR, that is clinical pregnancy rate, live birth rate, multiple live birth rate, number of pre-ovulatory follicles, endometrial thickness, cancer risk, all these parameters were more better in low dose HMG. So in comparison with CC, I think pure gonadotropins is going to be always better, but again, it comes as a second line drug. Okay, now you can use them, but always I prefer that whenever you want to use them, do not start directly from second day 150 dose. If you are using HMG, you use only 75 IU as a starting dose. If you are using recombinant FSH, only use 50 IU. Is the average dose you can use of recombinant FSH. Always assess it after 4 to 5 days of administration of gonadotropins. What is the response? So that if it is too much, you can step down. If it is not, if it is adequate but slow, you can step up these doses by maybe 12.5 to 25 IU of recombinant FSH step up you can see. So it is again a very good drug, very good protocol. The only problem again is whenever pure gonadotropins you are using, we need to understand that little duration consumption of gonadotropins is more. Chances of premature LH surge is more with gonadotropins. You have to give luteal phase support in these patients. You have to keep a track of LH surge. Use of antagonist is going to save your lots of cycles. So don't forget these all principles when it comes to gonadotropin cycles. What about IVF? Now, IVF is offered as a third line therapy. Again, I'm going by 2023 guidelines only. IVF is offered as a third line therapy where first or second line ovulation induction therapies have failed, and in absence of absolute indication of IVF, means there is no male factor, no tubal disease, those everything tubo-ovarian relation is maintained, all is normal, pure unovulatory. If your first and second line ovulation induction therapies have failed, then comes IVF. Till that time, you don't need to advise them IVF as a first line. Now, whenever you are planning IVF for PCOS patient, GnRH antagonist protocol is preferred, okay, and because we have advantage of using GnRH agonist as a trigger, and it will reduce the chances of OHSS, and also we have to vitrify all the embryos so that we can do that what is called distant embryo transfer or referred embryo transfer, that is frozen embryo transfer later. I think that is the best protocol, and this is how you have to do it. Use HMG or recombinant FSH, both are equal. It is completely administrator's wish, and after 4 or 5 days later, you can go for fixed antagonist protocol where day 5 you use cetrorelix. If you are following flexible protocol, you have to wait till dominant follicles reaches 40 millimeter and then you add a GnRH antagonist. Both the protocols are the same, doesn't matter. None of the antagonist protocol is superior to each other. They are same. And once adequate follicular growth is there, you use GnRH agonist as a trigger and do a oocyte retrieval and do a embryo freezing. So to summarize, friends, ovulation induction in PCOS needs individualization. Now, if you ask me, sir, what is the individualization in this patient? Yes, I think insulin sensitizers, with the new evidence, we need to individualize our approach. Okay. With the ovulation induction protocols, guideline says letrozole first. Before jumping with the pure gonadotropins, you can individualize patients with letrozole, with gonadotropins. Just now we discussed how we can do that. There are two ways. We give 5 days letrozole, then gonadotropin you can start, or just give 2 days letrozole and 4th day onwards only you can start gonadotropins. So combining gives you better clinical pregnancy rate than only clomiphene alone or clomiphene or metformin. Metformin is as an insulin sensitizer, is a very, very useful drug, but we know their side effect. sometimes patient do comes with a severe gastritis. So we need to understand that can we give them minoxidil 2 grams. So you have a good evidence substitute now where 4 gram of minoxidil can give you better results than metformin. Though I will say these are, please don't take it as a pinch of salt because it is just 1 or 2 studies in 24. Okay, probably we may get larger size study and probably minoxidil may replace metformin. We don't know. But still now metformin is a proven drug. We have to use metformin to most of the patients. Sometimes can we give metformin and minoxidil together? Yes, there are a couple of papers where they have proven that if you give both together compared to only metformin, these patients who receive combination, they shows a promising result. Ovarian drilling is not a first line treatment. In fact, it is the third line treatment. Okay. In fact, after you should use it only for those patients whose follow up for the treatment is questionable. I think that is where only ovarian drilling may come, or ovarian drilling in case if you have such patient who is a PCOS and has a severe OHSS, because ovarian drilling has an advantage of reducing the OHSS. But I think with agonist and freeze-all strategy now we are not worried about it. So I think probably I won't recommend for that indication drilling. And antagonist luxuriously helpful to prevent premature LH surge in gonadotropin cycle, and that's very, very important points. So thank you very much for your patient hearing. I hope I could give you all the recent evidence about different aspects of infertility management of PCOS patient, keeping 2023 guidelines in mind. Thank you very much.
That was an excellent talk, Kunal. And you have done full justice to the management part, how it has cleared our doubts about the use of certain controversial therapies like myo-inositol. You talked at length about your own experience with letrozole, how you have modified the oral ovulagens to choose to, be maybe kinder to the patients, to be, more systematic with the therapy, more efficient. So thank you so much for the talk. I would invite Dr. Aradhana and Dr. Kusum Madam to comment, please.
Dr. Kundan, it was really a very good deliberation. Most of the things you have covered. There are few things which I would like to know, because you have lastly mentioned that you there is little good, response when you combine metformin with the myo-inositol. So, is there any, dose which is defined? I don't think there is some standard dose which is defined, that how much metformin and how much is the myo-inositol you have to give.
Yes.
You have told 4 grams of myo-inositol if you are giving alone, but if it is in combination, can you tell us? To our,
yeah,
because I think use combination.
Yeah, sure. I think in this study, which was there are a couple of 2 studies which have used combining metformin and myo-inositol, and in these studies they have used 600 of myo-inositol and combined with 500 of metformin, and they have given twice a day schedule. Okay, so you are giving something close to 1200 milligram of myo-inositol per day. Okay, with 1000 milligram of metformin. So that's combination has given a better one Agrawal, Dr. Agrawal studies from Delhi, which has shown that live birth rate close to almost 55%. That was a cumulative live birth rate with those drugs. And there was another study where they also proven that the clinical pregnancy rate and implantation rate was better with this combination. So the question you asked me, any dose finding studies. So this was only couple of studies which has given, and there they haven't used as a 4 gram per day. When you want to use alone myo-inositol, then probably you have to think of 4 gram, because see, this is what we have also understood, because we have used only myo-inositol also in the past instead of metformin, but we did not find that great results.
Protocol, right? There's no standard, combination right now. So these are the few studies which are telling about this, and they have done their own titration of the doses. And secondly, had they used it alone or with the clomiphene or with letrozole or with the gonadotropin?
I think it was a pre-treatment followed by ovulation induction with letrozole. So it was a pre-treatment. These both the studies, not alone.
And one more thing that you have told us like there is a like little bit of superiority of letrozole over the clomiphene, especially when you add gonadotropin. But I know still there are a lot of people they have maintained their confidence on clomiphene, and especially if it is like a unexplained kind of like ovulatory PCO. If it is a ovulatory PCO, she is already ovulating, and but she is PCO, as per diagnosis, like androgenic character and ultrasound appearance. So maybe like these two factors are there, although she is ovulating. So, do you think clomiphene is a better option in comparison to letrozole?
I find it clomiphene as a good drug into a normo-ovulatory patients. Okay, I'm not talking about PCO normo-ovulatory. I'm talking about normo-ovulatory whose cycles are absolutely regular, which is we label it as unexplained infertility, where the semen factor is normal, where the tubes are fine, your uterine factor is normal. She's got a regular cycles. Those are not anovulatory. And in this patient, if she comes with infertility, so first 2 cycles or 3 cycles, clomiphene is your first choice. Even letrozole has a similar efficacy. So it is either or. It's not that clomiphene is better in this. Either you use clomiphene or letrozole. It is going to have a same effect. But when it comes to anovulatory,
Actually, what I feel like she is already ovulating. So one follicle she is already forming. So we can give her like a little bit of extra advantage of making 2 follicles. I would not say more than 3 follicles, but yes, 2 follicles are good enough, and then we can give clomiphene.
that's what I said. That's what I said. They are both are equally better. That's the area where we will use clomiphene. Okay. But in anovulatory patients, letrozole still stands better than clomiphene. Yeah. Others you can use clomiphene, no problem.
Okay. And what do you see the future with the now Elagolix is in the market? So let's talk about the new kid in the town, because previously because of the cost factor we were not using antagonists too much, and just for the postponement of the cycle if you are like weekend you want to save your Sunday. So now what do you think? Would you like to give it regularly once it is like recommended for the NRT also?
Right. Now, I think we need to understand, yes, that oral formulation is the biggest advantage than injectable, especially
And
comes
cost?
to
Cost?
elagolix and the cost, of course. But, right now, let me tell you especially those 4 studies, that is class 1, class 2, class 3, class 4, where elagolix has been studied in endometriosis patient. Now, they have been found to be pregnant. Certain patients were pregnant when patients were taking elagolix, and all 40 patients had a congenital abnormalities. Okay. So though it was not a part of study to assess this, but they found that elagolix used for endometriosis, patient conceived, all patients had a congenital anomaly. So it is not a safe drug for pregnancy. That is one thing which we need to understand. But now we need to explore this very properly, because we are using it in a follicular phase during your follicular growth, as we use injectables, where a washout time period of at least 10 to 12 days, or even in case of say freeze-all strategy, you have almost 6 weeks washout period. So probably it may not matter you, but unfortunately we do not have elagolix studied into IVF as a kind of a pituitary downregulation agent. So we don't have evidence yet. Okay. So there were only few case reports are there where they have used it.
That's what I was about to tell.
So those are only case reports. So probably we need to do a prospective randomized control trial when
for this premature illness, or for the post this thing.
Yeah, we need to study these 2 groups for the outcome. Specifically outcomes I'm talking about. Okay. We know cetrorelix outcome. For sure we have evidence. We don't have evidence the reproductive outcome and effect on pregnancy, especially the neonatal malformation. We don't have any evidence. So right now we need to plan something like this kind of prospective study and see. And because we need to tell the patient that we have something back of the hand, some evidence where it shows that elagolix and you got pregnant and there are all congenital anomalies. So we need to be very cautious. So we need to wait for this, and then only we will see whether it can be useful
For
there.
the down regulation and other things, I think this is safe alternative and cheaper alternative.
Sorry?
For down regulation, for the like high LSH patients, or for to bring the patient into the batch IVF. for for first 3 days when to synchronize the cohort and other things. For these
Yes,
purposes,
I think physiologically, yes. Physiologically, yes. It is a good drug, oral drug. You can use it for a short time. But I think still you need to do it, use it, develop your
that's
own
what I
experience.
was asking the question there for the future point of view.
Yes, I think
right
we
now
need
we
to
don't.
explore. It's a good area to explore. I think it might replace if it comes out that using and having that free pill-free time period probably may not give any congenital anomalies in the neonate. So yes, I think future we can look for that oral form of elagolix instead of injectable antagonist.
Okay,
Thank you so much, Dr. Kundan. Thank you so much, Dr. Aradhana, for that interesting discussion. I'm sure, I think by the time next guidelines come on antagonist, we will probably be shifting to oral antagonist. But as Kundan rightly said, it requires lots and lots of studies before this phase 4 trials, actually bring the drug into the market for general use. So that brings us to the end of the session 2. Thank you so much, Dr. Kundan Ingle, for being a part of this and sparing your valuable time just so close to New Year for being with us and enlightening us. Thank you very much.
Thank you, Monica, for inviting us.
Thank you. Thank you, Dr. Aradhana. Thank you, Kusum Madam. And Kusum Madam, would you like to speak a few words? You are muted, ma'am. Kusum ma'am, would you like to speak a few words? Ma'am, आप muted हैं. Madam, आप muted हैं.
Okay.
Yeah.
Thank you, Dr. Kundan and Dr. Monica also. First of all, I would really like to appreciate the way you have individualized every step of the treatment in cases of PCOS, right from how to take the help of GLP-1 receptor agonists in weight loss, because that is a real challenge, and use of every molecule one by one. But I want to ask you one thing, that you have said that most of the studies say that using 5 milligram of letrozole is giving better results than 2.5. So do you want us to use, because most of the molecules are 2.5 milligram preparations. So you use them in a BD dose or 2 tablets at one time?
No, I won't recommend you as a first cycle. You should start with 5 milligram. I won't recommend that.
No,
You should.
in later cycles.
Yeah, in later cycle, you can give 2 HS tablets, that is 2 tablets together at bedtime or maybe after dinner for 5 days. So that I will suggest you to do that.
Okay, one more thing I wanted to ask you was, suppose the patient has conceived, for how long would you like everyone to continue to use myo-inositol or metformin?
Okay, I think guidelines are very clear until now that metformin do not help us to improve live birth rate. Once the patient is conceived, probably there is no role of continuing metformin or any myo-inositol right now. Okay, now if the patient has glucose tolerance test is purely showing insulin resistance, there's only one role of giving 4 gram of myo-inositol for a prevention of gestational diabetes. And that kind of even guidelines are there, consensus statements are there since 2018. Okay, so in that case, you can give 4 gram of myo-inositol continuously, and that is going to, whole reason is to prevent gestational diabetes. But metformin has not been proven that it improves, it reduces miscarriage rate or it improves the live birth rate. That era is gone where we used to continue metformin till 12-13 weeks and then we used to stop it. So
yes, previously we used to continue in first trimester.
Yeah, so that is no role, and evidence is clear that we can stop metformin once we have achieved pregnancy.
Okay, one thing I just what I generally do is, it is very easy to tell the patient to lose weight and come 2 kg or 3 kg per month. And what I advise my patients and what every patient is liking is, I tell her to take YouTube ideas for good salad recipes. And I ask her कि ये YouTube में से recipes देख के you take full stomach, you take full lunch with salad fun once, and then after 1 or 2 hours, if you want, then you can go for your lunch. So that is working good for me.
That's good.
Yeah. But your talk was excellent and great, Dr. Kundan.
Thank you so much.
Nice to listen to you.
Thank you so much.
Now we proceed to the panel discussion. Thank you so much, Dr. Kundan and Kalyani. And I request Dr. Purva to please, Purva or Nandini, either please start the
Yes,
panel.
ma'am.
Yeah.
Now for our interesting panel discussion on PCOS management across women's life, I request Dr. Monica Singh ma'am to moderate the panel. She has been presently elected as Joint Secretary and Treasurer of IAGE MP chapter. We congratulate
Thank
you,
you.
ma'am.
Thank you, Purva. Please introduce
Yes, ma'am.
quickly all the panelists.
Yes,
All the
ma'am.
panelists are very, very respected gynecologists of Bhopal city, and we welcome them here. And recently, I've listened to a few of them in a physical meeting. They were brilliant. So I thought we will do it again online for the benefit of the larger audience. So Purva and Nandini, please
Yes,
introduce the panelists for us.
Hello.
Yeah,
Am I
Purva.
audible?
Yeah, you're audible, Purva. Please start.
For our first panelist, Dr. Akriti Jain, she is presently Associate Professor Chirayu Medical College Hospital, Bhopal. She is trained in ultrasound and is been trained in basic infertility. We welcome you, Dr. Akriti, for your valuable inputs.
Thank you so much, Dr. Purva.
Next.
Next panelist is Dr. Anand Dora, sir. Sir is presented a professor of AIIMS Bhopal. He has presented various papers at national and regional conferences. We welcome you, sir, for our panel discussion.
Next, we have Dr. Bharti Singh. She could not join the panel, I think, due to some emergency. Next, Dr. Vishal. Next, we have Dr. Geeta Katayat Rai. She is presently Associate Professor.
Hello.
Hello.
Yeah. Any problem? Any problem, Purva?
Okay, I proceed, ma'am. Our next
Yeah,
panelist
please,
is Dr.
please.
Geeta Katayat, madam. Madam is presently the Associate Professor at RKMCHRC, Bhopal, and she has received the Women of Substance Award in 2023. Our next panelist. Our next panelist is Dr. Gunjan Chaudhary, madam. Madam is presently the Assistant Professor at CMC Bhopal. Moving to our next panelist. Dr. Isha Zubair, madam. Madam is a director and IVF specialist at Unique Hospital, Bhopal. We welcome you, ma'am. Our next panelist. Dr. Neha Tiwari. She is presently the assistant professor at GMC Bhopal, but she could not join due to her ill health. Next panelist. Dr. Nishi Mitra, madam. Madam is professor at Ellen Medical College, Bhopal. We welcome you, ma'am. Our next panelist. Is Dr. Shivani Badal, madam. Madam is presently a consultant at Sagar Multi-Specialist Hospital in Bhopal. We welcome you, ma'am. Our next panelist, Dr. Sonal Jain, ma'am. She could not join because she is in journey. Moving to our next panelist, Dr. Shweta Agarwal, madam. Madam is director presently at the Ashoka IVF Care Hospital. It's an honor to have you, ma'am. Welcome, ma'am, for the panel discussion.
So here we are with the galaxy of panelists, and this is a very simple and to the panel discussion about practical take-home point. So please don't bother about who is answering first. Whoever wants to answer can just, raise a hand. You have, raise hand option at the bottom of your screen. Where is it, Purva? Where is the raise hand thing? I can't see it in my this thing. Okay, doesn't matter. Doesn't matter. Always doesn't matter. It's not there. So anybody can speak. Anybody can answer the questions. So I'll start sharing my slides. Can you see the slides? Are the slides visible?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am. We can see the slides, ma'am.
Right, I'll put it on a slideshow. Right. So here we have, I would request all the panelists to please put their videos on so that we can have a one. This case-based panel discussion, and in this discussion, Nandini and Purva are there with me to help me out. So we have the panelists already introduced to us. We welcome them all. And today we'll be speaking about the practical aspects of the international evidence-based guidelines for assessment and management of polycystic ovarian syndrome, which have been put together by all these bodies which are listed at the bottom. And the chief editor is Helena Teed from Australia. So these include 254 recommendations and practice points. Aim is to promote consistent and evidence-based care to improve the experience and health outcome in PCOS, because everywhere globally, women are still experiencing a delay in diagnosis and dissatisfaction with the care that is given to them. The prevalence is huge. We have a global prevalence of 10 to 13% internationally, and by Rotterdam's criteria, and it can go up to 30% in adolescents. So PCOS is affecting as many as 1 in 10 women. Maybe it's only it's 1 in 8, by the current standards. So what was the problem with the 2018 guidelines? The 2018 guidelines were good enough, formed very practically, evaluated across 6 continents by multidisciplinary doctors and the best available evidence. But the evidence behind the 18 guidelines was very low quality evidence. So now we have moved from consensus-based to evidence-based diagnostic criteria. That is the beauty of the 23 guidelines. 77 of these guidelines are evidence-based. 54 are consensus recommendations, and 123 are good practice points. So what they have basically, refined is they have come through to algorithms. We heard about Kaberi's talk. We heard in Kaberi's talk how beautifully and simply these diagnostic algorithms have been put to us. They have included AMH now only as an alternative to ultrasound in adults only. Ultrasound in adolescents is a strict no. AMH level is not compulsory. We are recognizing broader features of PCOS. For the first time, we are looking at metabolic risk factors, cardiovascular diseases, sleep apnea, psychosexual factors as a part of therapy. You are, working towards healthcare professional education. Everywhere you want to disseminate evidence-based information to the patient. You're promoting healthy lifestyle. Here, the consultant himself or herself is, motivated to speak to the patient. You are trying to give evidence of the medical therapy. If you're giving a choice of CC and letrozole to your patient, it is their right. It is the right of the patient to know from you that, madam, why are you prescribing letrozole and not CC? And of course, the fertility treatment has got to become cheaper and safer if you want the treatment to be evidence-based. So, Dr. Purva, please start the first case.
Our first patient is a 16-year-old girl. She presents to the clinic with concerns about her irregular menstrual cycles. She reports that her periods have been irregular since menarche at age of 13, occurring every 2 to 3 months. She also mentions excessive hair growth on her face and body, which has been progressively worsening over the past year. She has gained significant weight over the last 2 years and struggles with acne. There is significant maternal history of diabetes type 2 and obesity, but not in sibling. She has been moderately active in sports and playing basketball. She has a balanced diet but admits that occasionally she indulges in junk food eating. She denies of any sort of tobacco, alcohol or drug addiction. On physical examination, her height is 160 centimeter, weight is 70 kgs, and her BMI comes out to be 27.3 with normal vitals. And she's having acne on face, acanthosis nigricans on the neck, hirsutism on face, chest, and back. There is no palpable abdominal mass. Rest all findings are within the normal range.
Okay. Yeah. So the first question to the panelists is, after listening to this discussion about the first case, she's an adolescent girl, that do you think in your clinical practice, the PCO percentage of patients, adolescent age group, is increasing, or is it just overdiagnosis? You're doing more ultrasound, you're doing more diagnosis, they are coming to you more often. What is happening?
I think, ma'am, both things are correct. It is increasing. There is no doubt that PCO is increasing because of the sedentary lifestyle. But in adolescent, the radiologist people, they do the USG and they label it as PCOD. So patients having no complaints as such, and they come with a USG report saying that I have PCOD. So I think that using USG as the criteria, sometimes some people overdiagnose it. And we should know that in adolescent PCOS, the PCO morphology doesn't stand anywhere. So the incidence is no doubt increasing, but it is sometimes overdiagnosed as well.
So, Dr. Nishi, so what do you think has become better for you as a clinician as far as the adolescent diagnosis is concerned? What does the new guideline give you in your kitty, which makes
Yeah,
things very easy for
that
you?
is, we don't have to go for USG. If a patient is coming to us with irregular cycles, as we know in adolescent PCOS, if she's having cycles more than 45 days, that is 1 to 3 years post menarche, or after 3 years of post menarche, more than 35 days of cycle, or any single cycle more than 90 days, that says that the patient is having irregular cycle in adolescent. And along with that, any clinical sign of hyperandrogenism, that makes the diagnosis of PCO very simple. We don't have to go for any ultrasound in that case of adolescent PCOS.
Okay, now what do you do, Dr. Arun, if this patient is only presenting, she's an adolescent girl, she's only presenting with irregular cycles. She has no feature of hyperandrogenism at all. How do you tackle her? How do you convince her that she's okay and she might be PCO or she might not be PCO? How do you label her? She only has one feature, and that is irregular cycles. She presents to you at the age of 15 years. Her
Yes,
cycle,
madam.
tell.
Yes. So only one features will not diagnose the PCOS, but it can be labeled as a likely PCOS. And other parameters also you have to check for it. And what already told that no sonography in adolescent, but I don't believe that one, because sonography will rule out other causes of oligomenorrhea and amenorrhea. So to rule out
Sonography, Dr. Arun, sonography is advised. If you
Yes.
feel that you are suspecting some other pathology besides PCO, ultrasound is recommended. It is not that ultrasound is not recommended, but you need a definite indication.
Yes, ultrasound will rule out other causes of oligoamenorrhea, and it is not a diagnostic criteria for the diagnosis of PCOS in adolescent. That's
So
what I
this
want to
girl, so this girl where only one feature is there, either irregular cycles or hyperandrogenism, just mention in your case sheet or just mention in your medical records that she is at risk of PCOS. So just make a box around that, at risk for PCOS. Now this girl has shown you at 15 years. When she goes to another clinician at 19 or 20 years in another city, probably where she's studying or something, they'll come to know that this lady who has come to us was labeled at risk because of this reason. Now, at the age of 20 years, probably they will decide upon an ultrasound. Okay?
Correct.
So this
Correct,
is actually made because I have done n number of sonographies for adolescents. In the last, 20 years, 25 years of my practice, 2011, 2015, 2018, we were always doing ultrasound and I was struggling because first of all, these girls are little obese and chubby. Second, they're all wearing those tight jeans and everything. So you struggle to keep the transabdominal probe. Then you get a very poor vision. And then these ovaries usually appear multicystic. So the multicystic ovary of the adolescent girl confuses you with a polycystic morphology, which is actually not there. Okay. So I think it's made things very
Ma'am,
easy.
at risk also, we can counsel the patient that they are at risk, and we can advise lifestyle modification, which is very important as previously mentioned.
Yes, yes. So this is a good practice point that it is given in 11.4 for adolescents who have features of PCO but do not meet all the diagnostic criteria. They can be considered at risk, and reassessment is advised later at or before full reproductive maturity. And when do you call full reproductive maturity, Dr. Shweta Agarwal?
Ma'am, when the patient is reached around 18 years, then we have, because you have HPO axis immaturity in early ages after the menarche, like patient is 15 years or 16 years, HPO axis is immature. And nowadays the menarche age has also reduced. Like previously, we used to see that patient at 9th standard or 10th standard, they are getting the menses. But nowadays at 5th standard, like 9 years or 10 years, they are getting their menses. So 8 year after the menarche is also, we say that they are having that maturity in the HPO axis.
Yes, yes. So basically it is 8 years post menarche. Suppose the patient has had a menarche at 10 years, the reproductive maturity will be considered at 18, and so on and so forth. And when do you call this woman amenorrheic? Gunjan, when do you diagnose primary amenorrhea? Suppose an adolescent has come to you, her mother has brought that girl to you at 14 years.
Yes,
Madam
ma'am.
Abhita, Madam Abhita,
Ma'am,
किसका-
if she,
yeah.
yes, ma'am, am I audible? Yes, ma'am. It's if she has amenorrhea even after 3 years post thelarchy, that is the breast development, and if she has no like menses till the 15 years of age, then we call her amenorrheic.
Yeah, so 15.
And I would just like to add one point. It's nothing new, but for the adult diagnosis, we use Rotterdam criteria. We use like the out of 3, 2 should be positive. But somewhere there was a group of people who proposed that Carmen et al. In 2010, for adolescent, we need to have all the 3 to be positive in order to label them as adolescent PCOS. And also we should exclude other causes of irregular cycles in adolescents. Like ma'am has already discussed the other causes.
But Rotterdam's is made up of 3 criteria, out of which ultrasound criteria is compulsory in Rotterdam's. So 3 out of 3 cannot stand true for adolescents anymore. In fact, 3 out of 3 is not true for adults also. Rotterdam.
Yes, ma'am, but for adult, okay, ma'am, I read somewhere that they proposed, maybe.
Rotterdam's has stood the test of time. What is Rotterdam's?
Yes, ma'am.
Yeah, Dr. Shweta Agarwal, give me the Rotterdam's criteria, please.
Ma'am, anovulatory cycles or ovulatory dysfunction. That is the first. Second is hyperandrogenism, and third is the ovulatory features seen in the ultrasonography. Ovarian volume more than 10 centimeter cube, or
Perfect. So Shweta, how many criteria you need? How many criteria you need in
any
me PCO? Any 2?
Any 2.
Yes,
Any
ma'am.
2. And out of these, the third has been eliminated for adolescents, Gunjan. So
Yes,
that's
ma'am.
what I told
Not
you. in the-
recommended, not
Yeah.
to recommended for adolescents.
Ma'am, it's not recommended as such, but if it is present along with the 2 criteria, we can label her as adolescent PCOS. I didn't say that adolescent PCOS is like mandatory. We have already discussed it.
Again, I disagree. With due respect to your perfect knowledge, Gunjan, I would like to say, suppose this adolescent has come to
Yes,
you with
ma'am.
irregular cycles and or hyperandrogenism. She is carrying an ultrasound report from Baroda saying
Yes, ma'am.
transabdominal ultrasound with polycystic ovaries. Please disregard the report. Do not
Yes, ma'am. Yes, ma'am. Yes, ma'am. That is definitely true.
Yeah.
We can
Yes,
say
ma'am.
in
Definitely,
adolescent,
ma'am.
there are only 2 criteria to be seen.
Yes.
In adolescent, there are only 2 criteria to be seen.
2 criteria, yes.
Exactly.
This is the
So
2023
Akriti, these
guidelines
are all
made
the
it
panelists
simplified
we
for
have.
adolescents.
We have only Akriti, Shweta, Gunjan, and Nishi. That's it.
And Dr. Ishrat, madam, is there?
Ishrat is there. Okay,
Yes,
Ishrat,
ma'am,
now
indeed.
please tell me, this girl is taking oral contraceptive pills as prescribed by her gynecologist. She
Yes,
had
ma'am.
irregular cycles. She came to Dr. Purva Bhatkur. Dr. Purva Bhatkur started oral contraceptive pills for her at the age of 14 years. And the mother was also very modern. Mother said, ki koi dikkat nahi hai. Doctor, you can give OCs. Now, when she
Yes.
comes to you find that she might be, hyperandrogenic, but you're not finding clinical features because this patient goes to a beauty parlor every 3 weeks. She's very
Yes.
smart girl. She goes to a beauty parlor every 3 weeks. She gets waxing, threading, everything done. So tell me, she is taking oral contraceptive pills. When will you test her testosterone? And what test will you do?
Basically, if a patient is already on OC pills now, ma'am, so the test for hyperandrogenism like pre-testosterone and will not be reliable. So we'll have to stop at least for 2 to 3 months. Then we'll have to assess for hyperandrogenic biochemical
Very good.
values.
So you have to stop OCs for 3 months at least. And what are the 2 tests which are, done, which are recommended, though we don't do much clinically? They are the total testosterone and free testosterone. But here also the guidelines have given us the exact method of testing. You have to do mass spectrometry. Don't go by ELISA or RIA tests. Otherwise, you will not get a correct report. And there is something called a free androgen index, which, practically speaking, we are not doing. So I think we can, end at that. These are the 2 tests which are done, total and free testosterone, to assess biochemical hyperandrogenism. These just points which we are giving, which you can, totally start in your practice from tomorrow. You don't have to think that these are written in the books. These are written in the guidelines. So when you write on your case papers, advise total testosterone, advise free testosterone, please send to the best lab. Please check what the test the lab is doing and explain to the patient and her guardian that why are you doing this test? Okay, hirsutism is, I think I told you already that hirsutism and acne, they are, clinical correct features, but you have to rule out the pathologies. You have to rule out the organic causes. So why should we not rely on ultrasound? Why has ultrasound been totally thrown away out of the window? Please, can you enlighten us, Akriti?
Yes. First of all, thank you, ma'am, for the opportunity. And I think the recent ESHRE guideline 2023, it says it is excluding ultrasound only in case of adolescent. It is recommended for adult PCOS, but specifically for adolescent PCOS because they are going in that pubertal transition. And there the follicles are already being seen as polycystic at times, although they are not fitting into the criteria. And more often, because of being like unmarried and not active, the scans are being done transabdominally, which is not that accurate as compared to a transvaginal scan for the correct assessment of the number of follicles as well as the ovarian volume. So in case of adult PCOS, they are recommending more for only the 2 clinical features. One is the history and the clinical feature, and not relying on ultrasound, which is more for the adult PCOS, when we can already do a transvaginal scan for a better assessment of the ovarian volume as well as the number of follicles, which fits into the Rotterdam criteria exactly, like the number of follicles per cross section or in a single ovary and the ovarian volume. And as you said, ma'am, that already these PCOS patients of adolescent age group are more obese, and the transabdominal ultrasound does not give that accuracy for that ovaries to fit into that Rotterdam criteria of ultrasound.
Yeah. Okay. Thank you for the lovely answer, Akriti. And of course, there is this typical, multicystic type of ovarian appearance, which you see everybody who has put a probe on adolescent tummy knows, there is a multicystic sort of ovary. I also did ultrasound for my own daughter. She was going to boarding and she had very irregular cycle. She's a mild PCO. So I did a scan and I found multicystic ovaries and all that, but I did not give her anything. She, I just told her to reduce some weight and everything. So she adopted lifestyle changes. So there is a significant overlap between the appearance of these ovaries in healthy adolescent and in actual PCO adolescent. So that's the reason we should, be a little careful. So we've already talked about ultrasound. I think we proceed because it's a long panel. Management guidelines. Okay, somebody can tell how exactly you counsel your adolescent patient for lifestyle change? Ishrat, her mother, her very, very loving mother is sitting with her. Mother loves her a lot. Mother cannot see her little daughter bhuka, pyasa. And this daughter is getting lot of pocket money. And she has got free like gym. She has, access to gym. She has got access to everything, music. But she is, how will you counsel her?
Actually, it is difficult in this scenario in such a young girl to counsel about the lifestyle changes. Even जैसे कि आप कह रहे हो ना, it is very difficult to mother also counsel regarding the weight loss. But we'll have to explain them. She might be having a future metabolic risk factor for insulin resistance as well as cardiovascular risk. So we should counsel them that maintaining active lifestyle and keeping the check on weight will have a long-term consequences. So we'll have to counsel just a minimal exercise in schools or college wherever she is going, not vigorous, not regularly gym, even if she is doing just walking and just restricting the calorie intake in terms of junk food will suffice. Initially, we should do a milder counseling in form of reducing the calorie intake and a little bit increasing her regular physical activities, which she is doing
And
regularly.
actually, what I have seen where the daughter is obese or maybe son is obese, I find that there's some problem in the kitchen of that house. I found that the mothers are using the kadai very liberally, the frying pan very liberally. Every now and then something is popped in the oil to fry. So it's like it's a liberal sort
Yes,
of
yes.
eating. You have to sort of restrict from the kitchen. That aapko like try to
Kitchen.
use, healthier and probably more, less oil recipes. You have to tell them to
Yes.
Google, you have to tell them to, all the modern things and everything. So basically lifestyle interventions, they start from home. And Kaberi very nicely said the SMART goals. The goals for
Yes.
lifestyle should be smart, measurable, achievable, realistic, and
Timely.
timely. Yes.
Time bound. Time
Time
bound.
bound or timely. So this is the type of exercise which is advised in adolescents. And okay, so now have I missed anybody? Everybody's here.
Dr. Shivani has joined.
Dr. Shivani. Dr. Shivani is there. Hi, Shivani. So just tell us about the OC. Your patient has come to you with adolescent PCO. You have diagnosed her because she has got mild hirsutism and she's got, facial hair. She's got a slight blackening of the skin of the neck at the back. And she is a BMI 27. Her mother is very, educated and a postgraduate, and mother is ready to use OC. Now tell me your choice of OCs and why. You have to deal with irregular cycles. You have to deal with hirsutism because children at school are teasing this girl about the hair. Okay. So how will you deal with this girl for her hirsutism as well as irregular cycles? Mother is ready for everything. Shivani, you have to unmute.
Hello, ma'am. Am I audible?
Yes.
Ma'am, first of all, as ma'am just now told, we have to teach her about the risk and the lifestyle modification. She has to reduce the weight and everything. She has to do a vigorous exercise because her BMI is also high. Moreover, saying to the hirsutism, we have to give those progesterones which have anti-androgenic properties. So we'll be preferring estrogen with cyproterone acetate. So I'll be giving a combination of OCs containing this. And along with that, I can advise her to go for laser reduction because she is a school-going girl, more of a lifestyle where she'll be bullied by the children regarding her hair, facial hairs and other things. So laser treatment would be a good option because it will reduce the facial hairs moreover. About the acne also, we can give tretinoins for the acne problems. And moreover, ma'am, the junk food and all should be avoided. And I'll tell her that the ill effects of all these things so that she won't be using them.
Okay, so Purva, you are our expert. Purva, tell me what is your choice of OCs and why? And why have these guidelines not totally recommended COC containing cyproterone acetate, anti-androgens? Why? They are not recommending this as the first line. Yeah. So what?
Ma'am, they are not recommending high dose because of the adverse side effects or the adverse effects, and they are mostly recommending the low dose ethinyl estradiol containing OCPs, and no specific OCP is recommended. They are just saying you can use low dose containing estrogen pills.
Cyproterone is not used because of the risk of venous thromboembolism.
Yes, yes, it is because of the adverse effects which are because we have to use it for at least 6 months.
They,
So
yeah, the guideline says that cumulative or long-term effect of using any low-dose OCP or cyproterone containing OCP is same. And cyproterone acetate is
But-
having high risk of venous thromboembolism.
yes, it is having the venous thromboembolism, which is an adverse effect of it.
Yeah.
So that's why.
So, I mean, you can go for the low dose COC with lifestyle. Anybody who is using metformin in adolescents?
In case the BMI is high, the patient is already having a BMI which is more than 25, she's coming in the category of overweight or more than 30 obesity. If the BMI is high, and I think even before that, we can check out for the impaired glucose tolerance also.
Yeah, this family belongs to a patient. This patient belongs to a family wherein you are seeing a mother with type 2 diabetes.
And obesity.
These parents, you are seeing a sibling, with the Hirsutism or something. You are seeing heart disease in the family. So this is a girl who is good for counseling, and you can start, not only lifestyle modifications, metformin also, but everything after proper counseling. Everything is the cafeteria choice has to be given to the patient, even whether it is fertility or whether it is adolescence, whether it is, psychosexual disorders, everything. The doctor of 2000 or 1990s, we became gynecologists in 1990s, late 1990s. That practice has totally changed now. Here, you have to really counsel your patient about everything and give her the pros and cons, because she has got everything basically on the net also. Okay. So Dr. Kundan has already talked about inositols. So we had this discussion when Purva, you were doing this panel, that inositol has, is a controversial thing in the guidelines. I would just like to tell you that inositol is neither a strict yes, neither a strict
no.
I would like Dr. Akriti to comment on inositol, if she has any experience or if she has read about it.
Actually, the recent guidelines are mentioning about the different inositol either alone or in combination. They are more of experimental as of now. Their long-term effects are very much limited. The clinical benefits, they are being already used by many people, but their long-term outcomes, and there is a lack of quality evidence also regarding that whether it is really beneficial. So until now it has been used, and they are mentioning about the correct dosages also, as Dr. Kundan sir has highlighted, that many people are giving, but the correct dosage of 4 grams per day, like 2 grams twice a day dosage, that should be gone to give its results. And previously, sometime when we were doing PG, there was some preparations which were coming out that there should be a specific combination of myoinositol with D-chiro-inositol, and a specific ratio of something around 1:63 used to be maintained.
1:40.
1:40. Sorry for that, sir.
1:4.
The recent guidelines also mention that same thing, that alone or in combination, it can be given, but the recommendation says that it is still in the experimental thing, and there is a lack of quality evidence on its benefit for PCOS.
So Dr. Arun Dora has to, I think he is quite anti-inositol. So I think last word from you, Dr. Dora.
I am actually not anti-inositol, madam. Actually, thing is that 4 gram of myoinositol per day will cost around 1,000 rupees, and a metformin tablet maybe, because the myoinositol tablet what you are getting, that is cost around 40 rupees or something, and that is having in some milligrams only, under 20 milligram, 30 milligram, maybe that much only. And in the combination form, if you are giving her 4 gram of myoinositol, then it will be 1,000 only. That much of amount she has to spend per day. And the metformin tablet, that costs only 2 rupees per tablet. So you have to see the cost to the patient also. And we are not having any definite evidence that myoinositol is working better than metformin, or it not having any beneficial effect on the reproductive outcome. Then that's why I am not so much for of myoinositol until we are getting any beneficial effect, proven beneficial effect. That's what only I wanted to
Yeah,
tell.
point taken, but I have some difference about the cost. I will get back to you about the exact cost of
Yes, ma'am.
myoinositol in government clinics as well as in private this thing. But all
Okay.
said and done, it's a good practice point that the women's personal goals and preferences should always be considered whenever we discuss these complementary therapies. That is the
Okay.
point to be considered. Yeah.
Mhm.
So we all know that 100% of the women with PCOS are fighting a daily battle, which nobody can see except themselves. Okay, so we have to consider be very, very empathetic and sympathetic with these patients. So hyperandrogenism, I think we've already dealt with. We have done all these scores which are clearly theoretical. So I think we can skip this. The Ferriman Galway, and there's another Ludwig score also. OCs containing anti-androgens, why are they risky? Dr. Nishi and Dr. Purva have told us. And these are a couple of pictures. Long-term health issues you have to tell the girls when they come to you. But I was having a talk with my kids the other day. They talk very less. You can understand both my kids are above 20, so they have no time to talk to mom and dad. But sometimes I do talk about, what is the current trend amongst you youngsters. So they said, Mama, something very good. These young people, they are not nowadays, they are not smoking much. No, they are not drinking much, but they are smoking a lot. So they said that it's very nice. We are not taking alcohol, but we are smoking. And this I correlated with the adolescents in UK. My sister is here from UK. So I asked her, Wahan kya hai? So she also said, there also adolescents are now drinking less, but they are smoking more. So just, I mean, the lifestyle and everything. So we come to case number 2 now. Nandini, can you take the second case, please? Is she there?
No, ma'am, she is not there. I'll just
Purva,
take
आप
the
ले लो,
second
आप ले
case.
लो, आप
Yes.
ले लो. Yeah.
Moving forward to our next case, a 29-year-old woman and her partner are seeing the gynec OPD for primary infertility. The partner has no previous medical history to note, but he's an alcoholic addict and he drinks about 8 units of alcohol per week and does not smoke. He works as a hotel manager. Women is having no previous medical history except that she has an appendectomy 12 years of age, and the cycles are between 31 to 46 days and very scanty at times but not painful. There is no intermenstrual or postcoital bleeding. She always had her normal smears and had never being infected by any sexually transmitted infection. On examination, her BMI is comes out to be 32, and with slight acne on her face and her chest. There are no abdominal scars, and the abdomen is non-tender with no palpable mass. The speculum and the bimanual examination are very much normal. So this is a couple visiting a gynec OPD with primary infertility. Ma'am, you are muted.
So Dr. Nishi, Dr. Dora, both of you are, very senior. So please tell us, how will you deal with such a woman?
This patient is having high BMI and cycle length is also in the oligomenorrheic range. And she came for the primary infertility. So first thing is that lifestyle modification, decrease in the body weight, exercise, that should be there. That should be advised first. And if the question is taken, the criteria for diagnosing adult PCOS is already taken. Any 2 criteria after the 3 of the rotator. And here in this case, first thing is that she should lose her weight. She should come in the normal BMI, and then we should look for the whether she is having regular ovulation or not. Then if not having, then you can go for ovulation induction, and that should be the priority. And before that, you have to exclude all other causes of infertility like male factors. All these things you should check it. That's all. Thank you.
Yeah. So another, a few points have to be added here. It's there on the screen. Nishi, would you touch upon these points? when you come you come across a patient who is having irregular cycles, she has come to you like day 60 of cycle, day 65 of cycle, will you give her straight away progesterone for withdrawal? What will you check? You're muted, dear.
Before diagnosing or labeling her as PCO, first, PCO is a diagnosis of exclusion. I would like to go for, I mean, she's having acne, she's having high BMI, but we have to exclude hyperprolactinemia, thyroid, and other causes as well before labeling her as PCO. And yes, if she's diagnosed as PCO, then
Everything is
definitely.
normal, Nishi. Thyroid is normal, prolactin is
And
normal, everything.
then we will label her as PCO because she's having acne, and we'll get an ultrasound done, and that will show the PCO morphology. And then definitely we'll reassure her. We will tell her about the preconception factors which she has to correct before we can start on the treatment. That is decrease the BMI, because that will increase her fertility as well as the obstetric outcome, which we know. And then we will give her the treatment options, where we know that the first line is obviously, as told in the previous lectures, that it is letrozole, along with that metformin, as sir has said. And now we are getting promising things about myoinositol. So definitely, as sir said, we can do a pre-treatment because she's a high BMI patient, so we can do a pre-treatment with metformin and myoinositol before starting her on letrozole. So that will be our first line of management. And definitely lifestyle modification has to be there, which is very, very important.
So you have to reassure. These guidelines have become softer.
Yeah.
These guidelines have become more like patient friendly. So this woman has to be reassured. They come sometimes totally hopeless and distressed that I'll never become pregnant. So you just have to explain to them you can become pregnant on your own with lifestyle modification or with little bit of assistance. There is no rocket science to make you pregnant. Of course, you start her on all the vitamins. Always exclude a pregnancy. There is many a time we have seen a patient come with amenorrhea 2.5 months. You put a TVS probe and you see a sac. Especially if this woman has been taking off and on ovulation induction agents, and especially after a DHL, a laparoscopy or something, they do a few drills. Now, I am not propagating LOD at all. But sometimes you do a laparoscopy, you do those 4 beautiful drills on both the sides, you leave the patient and you tell her, okay, you come after 1 or 2 cycles, and she comes pregnant. So probably that ovulation cycle sets in. And whenever you start oral ovulation inducing agents, always explain the cafeteria available to the patient. Tell her which drug I'm using, why I'm using, what are the side effects. And always, if at all you find in any patient, especially those working in Gandhi Medical College, AIMS, where you have no, sort of liability to be responsible for anything, you have to record the congenital anomalies. Any patient on ovulation induction and you find an anomaly, please record and report, because that is going to go into the data for a long time. So somebody was telling us, Akriti was telling us about FNPO, follicular number per ovary, follicular number per section, and ovarian volume. What are these and how are they useful? And what do you do practically?
What they're recommending in the revised consensus Rotterdam criteria, it is being mentioned that preferably always a transvaginal ultrasound should be done. And in that, either you see for the number of follicles per ovary. So the follicle number per ovary, that is FNPO, if it is more than 20. Or you see for the volume of the ovary, which is more than 10 ml. Or you see for the follicle number per cross section of the ovary, which should be more than 10. So
cross section, follicular number cross per section is for when you're using the 2D probe.
2D probe.
And when you're
Right.
using the 3D probe, you can use FNPO, you can use only with 3D probe. And FNPS is for 2D probe. So some facility don't have a 3D, and sometimes you don't have the time. Even I don't start a volume measurement of the ovary in every patient. How can you afford to do it? So you do a FNPS and you take out the ovarian volume estimate. So they have said, these guidelines have said that FNPO should be considered the most effective ultrasound marker to diagnose PCOM. Okay, so this is everything about ultrasound. So having said that, it's very, very important that all of us are perfect in our transvaginal scans. And it's always a good idea to even, turn the monitor towards the patient and show her the ovaries. It, she sometimes, knows how it looks and what is the, and you can show her a normal ovary also. I sometimes show a normal ovary to a patient and then I show her a PC ovary. Now, what is this is, sorry, Shivani's name is already written. I could not delete it. Is there any role of serum AMH? So Shivani, you can take this question. What is the role of AMH and how important do you find it is? Dr. Shivani is there? Who else is there, Purva?
Ma'am, Dr.
Shweta is there.
Aditi
Shweta
is
is
there,
there.
Dr. Ishrat
Yeah.
is there.
In
Yeah.
adult
Sorry,
PCO, we can very
Yeah.
well add AMH level for diagnosing and confirming our PCOS findings. AMH is
Yeah.
as per the latest 2023 guideline, AMH is included in that. It is not used alone, but along with ultrasound marker, it is used as in diagnosis.
But they
Yes.
also mentioned that using both of them, and it should not be an over diagnosis. Like if it is clearly looking as FNPO is more than 20, then you might exclude AMH level.
Yes,
Yeah.
definitely.
Yeah, serum AMH definitely no in adolescents and never as a single test for diagnosis.
Single
And
test, yes.
sometimes if you get a clear-cut PCO by other two criteria, you can even leave, AMH as a test. So this is how the guideline has changed the importance of ultrasound and AMH. So what are the preconceptional risk factors which are associated with a negative fertility outcome? Dr. Gunjan Chaudhary? Are there any risk factors you would like to correct? We've already talked about them, but is
Yes,
there any?
ma'am.
Yeah,
Yes,
please
ma'am.
let.
Ma'am, if the first of all, we'll look for the BMI of the patient. If the BMI is high, we would like to correct her BMI. And we have already discussed about the prenatal supplementation. So we can always give her vitamin D supplementation before any treatment we proceed. So we would like to correct that if there is any deficiency of vitamin D, and if there is any component of hyperinsulinemia, we can always give a pre-treatment of myo-inositol or metformin, and metformin, and maybe used alone or in combination to increase the insulin sensitivity. And if this will further, today nowadays we talk a lot about the adjuvants, role of adjuvants in PCO, ma'am. So we can also, if there is poor egg quality, we can also give them, nowadays melatonin has got its role. So that's why we can just look out for, and also they are talking about gut dysbiosis. We can also correct the gut dysbiosis by supplementing them with prebiotics and probiotics, ma'am.
Yeah, so these, of course, probiotics is again a chapter in itself. We are having a very, very nice webinar by the greatest speaker on dysbiosis, probiotics, prebiotics, and postbiotics. Dr. Mala Arora, Dr. Professor Mala Arora is speaking tomorrow in a webinar at 7 p.m. I'm the convener of that webinar, so I know. So anybody who wants to know, she gave us such a beautiful talk in Delhi in the master class that it was wonderful to listen how much she has analyzed probiotics. And she really gives you food for thought that what are postbiotics, which postbiotic I should give, which prebiotics should I give, what is the, what is the role? So I suggest all of you to listen to that talk tomorrow. Dr. Arun Kumar, please tell us what is the role of tubal patency test in this patient? She has never had a tubal patency test and I think she's 30, 29.
29.
So she's never had a tubal patency test. She has just come to you with a full-blown PCO. What do you do?
PCOS will not change the criteria for tubal patency test. And it is an individualized decision to do tubal patency test or not in this patient. And before doing tubal patency test, we should rule out the ovulation factors, and you should do the ovulation induction if necessary. And as such, per se, PCOS will not influence whether you have to go for tubal patency test or you will go early to the tubal patency test. So it is individualized treatment, and in this case, after ruling out all the other factors like ovulatory factors, male factors, then only you should go for tubal patency test.
Yeah. So it is highly individualized. It depends upon the personal preference of the physician. So tubal patency test can be left to counseling. The prevalence of infection in your setting, that patient, how much infection or repeated UTIs have she had in the past? Did she have any multiple partners in the past? Has she complained of any episode of PID in the past? Or suddenly in a TVS, Nishi, you do a TVS and suddenly on one side, left adnexa, you find some tenderness and the sliding sign is negative. Would you like to do HSG in that? You're muted, dear.
No, ma'am, if I am suspecting an adnexal mass, that means she can be tubercular as well.
No mass. There is no mass. You have put your TVS probe. Nicely, you go to the posterior fornix. You see the uterus, everything. You go to the right adnexa. You see a nice right ovary. Sliding sign positive. Left side, you find the left ovary adherent to the left uterus. Patient winces a little.
And then
start ovulation induction. Patient is not ready offhand for laparoscopy. Would you do an HSG?
if she's having adherent ovary, I'm finding adherent ovary, she might be a case of endometriosis then.
No. Adherent ovary doesn't mean endometriosis. I think we are diverting from the
Ma'am, it could be PID or something.
Yes, what I wanted to say, Nishi, was that this woman just has, some tenderness or maybe some sort of adhesion in the left adnexa. She's not having a freely sliding ovary. She's already 29, 30. You're going to start an ovulation induction cycle for her, which is going to cost her in private a good 15,000 minimum. So why don't you do an HSG? एक month से tension खत्म हो जाएगा कि she's got patent tubes and then you proceed. So in that individualized patient, at least I would like to do an HSG, but it's open to discussion. Purva may think differently, Shweta may think differently. Okay, so it's up to you totally to decide where to do a tubal patency test. I think you continue, Purva, with the next discussion. I have to do an IUI and come back. Okay, so.
Okay.
Yeah, just discuss letrozole versus clomiphene, and then you discuss this thing, metformin combination with this. I'll just be back in 2 minutes, right?
So moving forward, letrozole is preferred over the clomiphene citrate according to the guidelines. So Dr. Arun, why we have preferred the letrozole over clomiphene citrate?
So letrozole is having a high ovulation rate and live pregnancy rate. So take-home pregnancy rate is more with letrozole. So that's why it is preferred. And although it is not approved by FDA, not approved by many other organizations, still it is having advantage over the clomiphene citrate. The side effects wise, if you see both the letrozole and clomiphene citrate are same, and live pregnancy rate is more. That's why letrozole is preferred.
Sir, is there anything would you like to tell about the endometrium in the bone?
Yes. Clomiphene citrate is having the effect on the endometrium. That means it is anti-estrogenic at the endometrium, and letrozole is not having that effect. So for the optimum conception or implantation, endometrium should be properly formed. So at least more than 7 mm. And letrozole having the advantages over the clomiphene on that aspect.
Sir, in lifestyle modification, we have introduced metformin. So, would you like to say something about metformin?
Yes, metformin can be added with letrozole and also can be added with clomiphene citrate. So that is having some additive effect. So individually, letrozole and metformin may not be having that much of effect, but in combination, that is better than individual approach.
Okay. And moving forward, in women with PCOS, is ovarian surgery effective in improving the fertility outcomes?
Ovarian surgery means if you are thinking about laparoscopic ovarian drilling, so that should not be the first line. Laparoscopic ovarian drilling should be done in those patients who are difficult to follow. Second thing, those ovarian volume is very high. That means the medulla is very thick or very bulky, and that is secreting much amount of androgen. So in that case, you can have the ovarian relief to decrease the total androgen level from our body.
So is there any specific level of AMH for the ovarian drilling?
So AMH should be more than 7 to recommend for ovarian drilling.
Okay. So moving forward to our last case, that is a 28-year-old woman with known PCOS, presents with a history of 2 consecutive miscarriages. She is currently 8 weeks pregnant and taking metformin. Ultrasound shows a viable intrauterine pregnancy with a gestation sac, which are corresponding to her dates. She is concerned about the miscarriage. So how does the PCOS is responsible for the recurrent pregnancy loss? Anyone would like to take this question?
Acha, we have gone on to the next case, Purva.
Yes, ma'am. We have moved on to the case.
Okay.
Yeah.
Yeah. I just wanted to put one point. When sometimes we are confused whether to start metformin or not. Remember, when metformin is superior even to placebo. If you are giving metformin to your infertility patient with diagnosed PCO, you are definitely doing her some good. It will improve the live birth rate, clinical pregnancy rate, and overall pregnancy rate. Okay, so there is definite evidence behind it. And this is how metformin improves your ovulation induction. Not only it, synergizes with the ovulation induction drugs, it improves ovulation. It acts as an effective insulin sensitizer, corrects the hormonal imbalances. It is not a first line drug, so you have to tell the patient that it is working, very nicely with combination therapy with oral ovulogins as well as gonadotropins. It may improve menstrual regularity also. Especially when you use it with gonadotropins, you get reduced incidence of OHSS, and you have to give her the GI side effects, that everything. Now, this is another talk which I took in Fertivision. Whether you combine CC with metformin versus compared with CC alone, or you combine CC with metformin versus metformin alone, you will get improved pregnancy rate. So metformin is one drug that 2 rupees per tablet, which is sort of a magic drug for PCOS. So Dr. Shweta can take this question. What precautions do you take when you start gonadotropins in PCOS stimulation, whether you're using for IUI or IVF? What are the precautions you take? What are the take-home messages you would like to give for gonadotropin use?
Gonadotropins can cause OHSS in patients with PCOS, so we have to start with the low dose. Like we cannot start like we usually in IVF we start with the 350 or 300. So we have to see whether we can start with 150 or 225 IU of gonadotropins. And hello, am I audible, ma'am?
Yeah, but your voice is breaking. If you are in a low connectivity area, please move to a better connection.
Yes, ma'am. And in IUI, we can give gonadotropins for 3 days from 7 day onwards, 7, 8, 9. But in a low dose, gonadotropins is recommended in IUI as well. And we have to see if the multifollicular development is there, then we can abandon the cycle in cases of IUI. And in cases of IVF, if we are starting with a low dose, then we have to see the estradiol level. If it is adding more than 5,000, so we have to give the trigger, not SCG trigger, but other triggers like triptorelin can be given for avoiding the OHSS. And we should do the FET cycle more in cases of this when we are giving gonadotropins in PCOS rather than doing a fresh transfer.
Yes, and antagonist protocol we should use in IVF cases, and antagonist protocol.
Yes, ma'am. Is there any?
I don't think, Monica ma'am, we cannot.
Ma'am,
I cannot
screen
hear.
share has been stopped.
Okay. Madam is not there.
Purva, can you call, ma'am?
Ma'am is here only.
Ma'am is there.
Screen has gone. One sec. I'll try to share again from the desktop. Actually, my connection went for some time, so I was out of the meeting for a few seconds. So now I have to open the, yeah. Now I've come back. Can you see my slides?
No, ma'am.
No, ma'am.
You can't see. Okay, so let me try again with multiple windows. And I share again. Yeah, I got it. Can you see again?
No, ma'am.
Not yet.
Can you see? Can you see the slides?
No, ma'am, no.
No.
Meeting से left, okay. Hello, ma'am, are you there?
I think she will connect in some while.
I've connected, but this sharing is giving me a little bit of problem. Let me try.
Ma'am, should I share the screen?
Yeah, now is it visible?
No, ma'am.
No, ma'am, no, not yet.
Not visible?
No.
Okay, then you share. Purva, please share. I'll stop share. Yeah.
Now the screen is visible?
Yes, definitely.
Yeah. So, how does, ma'am, are you able to see the screen? I think.
Ma'am has gone again, I think.
Okay, how does PCOS contribute to the recurrent pregnancy loss?
So in PCOS, we have that defective corpus luteal formation, decrease in this progesterone effects, and defective we have luteal phase defect as well, and is endothelial dysfunction, and we have defective the oocyte as well, because the recruitment occurs early in the primordial stage, and the atresia is also not happening, apoptosis is also not happening. All this lead to this recurrent miscarriage in cases of PCOS.
Very rightly said, Dr. Shweta. Now, what are the obstetric outcomes in such patients? Dr. Nishi, would you like to take the question?
In PCOS patient is we can label it as a high risk pregnancy because they have a higher risk of pregnancy losses, as we discussed, and then higher risk of gestational diabetes because they have an inherent insulin resistance, hypertension, FGR, preterm delivery. So we have to keep that patient as our high risk patient and start our monitoring and everything from the very first time she visits us or she becomes pregnant, which includes monitoring for gestational diabetes, monitoring for hypertension, and we can start all the prerequisites which we have the little ones to improve her obstetric outcome.
Yes, very rightly said. So PCOS basically increases the risk of higher gestational age weight gain, along with miscarriages, gestational diabetes, hypertension in pregnancy, preeclampsias, IUGR small for gestation age babies, and low birth weight, preterm delivery, and cesarean section. Also, this is the very
Cervical insufficiency is also there in cases of PCOS.
yeah.
So when we are doing
This symptoms
NT-NB,
that
then
can lead
at
to
that time,
preterm.
at that time you should see for the cervical length. If it is less than 2.5, we should do the needful.
Go for the cercology. Yes. So should she continue metformin throughout her pregnancy? What is your say, Dr. Gunjan? Hello, Gunjan, are you there? Dr. Akriti, would you like to take the question?
Regarding metformin, I think if she's taking it preconceptionally and has already conceived, I think we should just have a glucose tolerance also, ideally preconceptionally. And once, if she has already come with pregnancy and already on metformin, at the first visit itself, a glucose tolerance test should be done. And looking into her BMI, because we do not want, I mean, the normal weight gain is to be there, but excess gestational weight gain should not be there. So assessing according to the BMI and her glucose tolerance test reports. Based on that, we can continue metformin for a long time.
Yes, very rightly said. It is basically the metformin in pregnancy of PCOS is not usually preventing gestational diabetes, late miscarriages, hypertension in pregnancy, preeclampsias, macrosomias. But yes, there is some role in preterm protection for preterm birth. There is definitely a role for this. So, what additional tests or treatments would you like to recommend to reduce the risk of pregnancy loss in such patients? Dr. Arun, would you like to take the question?
Tests like glucose tolerance test can be done to see whether she is having over diabetic or not. And if it is there, then we have to treat it. So are you asking about the patient which is not pregnant yet or already pregnant?
She's pregnant. She's pregnant. But yes, if such a couple comes to you with a recurrent pregnancy loss and she's PCOS, so what are the tests you would like to do before she
So
conceives?
okay, before she conceives.
Yeah.
So first thing is that she should be euglycemic. That means diabetic status should be normal. That means glycemic status should be normal. That is the most first thing you have to see. Then her BMI should be appropriate, and she should take the folic acids. And no other systemic disease like collagen vascular disease, hypertension, metabolic syndrome should not be there before embarking on the pregnancy.
Yes, sir. The point is very well taken. Now, so some take-home messages are that pelvic USG has no significance in adolescent PCOS. Irregular cycles along with hyperandrogenism are the key features of PCOS, and the long-term health risks should be considered and treatment should be given accordingly. This treatment, along with some emotional well-being, has to be taken into consideration in the management of PCOS. So I would like to thank all my panelists for their active participation in the panel and very fruitful discussions on the recent guidelines. Thank you so much.
Thank you, madam. Thank you.
Thank you so much.
Thank you so much.
Thank you, Dr. Purva, and
Thank you so
all.
much.
Thank you.
Thank you, Purva.
Okay.
Can
Dr.
we leave
Vishal,
the
ma'am
meeting,
is.
Purva?
Huh? Yes, ma'am.
Madam is joining, or can we leave?
No, I'm just asking, ma'am. Just
Okay.
I think there is some network problem on her side. So
Will you just inform her?
yes, I'll inform her.
It's okay. Thanks
Thank
a
you so
lot.
much. Thank
Bye.
you.
Good night.
Thank you, Dr. Vishal.
Thank you.
Thank you.